Bwrdd croeso. I think we need to unmute. Are you okay?
Yeah, just call that.
Bwrdd and croeso, everybody. Welcome to our board meeting. I'd like to say a special welcome to our new board member, Mrs. Chantel Patel. We have a really packed board meeting today, some very important papers. So if you could all restrict yourselves to concise questions and concise answers in order that we can go through the papers thoroughly and give them all due attention. So thank you. I'll go straight to apologies.
Thank you, Chair. This morning we have apologies from Anne Murphy. We have apologies from Mr Mansell Bennett, the Chair of the Community Health Council, but he's represented by Dr Barbara Wilson. And we've got apologies from Cyhoeddus. And just for information, Chair, we've got Karen Thomas joining, Joint Head of Dietetics, joining for item 3.3, Libby Ryan Davis for item 3.5, Bethan Lewis for item 4.9, and Rebecca Jewell from Healthcare Inspectorate Wales will join us to present their item at 5.2, Chair.
Thank you, Jo. Diolch yn fawr. And do we have any declarations of interest?
Yes, Chair, we do have one declaration of interest from Maynard Davis in relation to the sale database, which is contained within the Chief Exec's item. Maynard is part of the Sale Information Governance Review Panel, Chair.
Thank you very much. And if any other members have declaration of interest as we go through the papers and we discuss certain items, if you could please indicate. Thank you. We go on to item 2, which is the minutes of the public meetings held on the, first of all, I'll go to the 28th of July. Are there any inaccuracies or any points people would like to draw to our attention? Board happy to accept them as a true record. Many thanks. And I go on to the minutes of the 4th of August. Any inaccuracies? Many thanks. And then if we go to the matters arising and the table of actions from those 2 board meetings.
Chair, we have got comments from Mr Newman.
Sorry, I missed that.
On the, sorry,
the action log, that's
yeah.
where we are.
Yeah.
That's fine. Thanks, Paul. Do you want to raise it orally?
Yeah, shall I come in? Yeah, couple of things in relation to the action log. First of all, PM 22-113, the report of the Audit and Risk Committee, which was considered at the last board meeting. The concern, I think, that was expressed in Audit Committee related to the processes which the Health Board was using in order to make sure that people on the waiting list were properly on the waiting list. The progress report seems to relate to a fresh validation exercise as opposed to the Health Board's processes in checking to make sure that people are recorded correctly on the list. Can we clarify what the position is in relation to that, and in relation to PM 22-125, is there a start date for the PBS service?
Thanks, Paul. Can anybody answer that, please?
Andrew would be the first one, Chair.
Okay, Andrew.
Sorry, just a second, just working with my screen. I'm having issues with the buttons. There we go. I think that's still not quite working.
We can see you, Andrew.
Okay, thanks. I think so. Sorry for that. May have been a slight misunderstanding in relation to the minute and the progress point. I think the key point would be that the management of the waiting list and the validation is obviously an ongoing. It's something that's an ongoing process, and there's an ongoing kind of training and awareness program that the director are working through. I also know that we've been looking to appoint, I need to clarify the start date, but we were bringing in somebody with specific expertise to help make sure that our internal processes were very, very tight around this, recognising the importance it has in delivering our overall position. What the progress update refers to there in relation to action PM 2113 is an additional phase of validation that Welsh Government have requested that we undertake and are supporting. So apologies for the confusion. If you'd like, Paul, I'll give you a more detailed update outside of the meeting if that would help as well, to rectify that. And in relation to PBS, we heard at the Children and Young People group on Friday that there is an SBAR that's being pulled together that's setting out the proposal for the development of that service. It wasn't ready for the meeting on Friday, but I'm anticipating it will be ready over the next 4 to 6 weeks when we're due to meet next as a group. The challenge within that, which I'll flag straight away, is there is potentially for us to establish a service a resource requirement. So there will be some work for us to do to understand whether there are sources that we can go to support funding of that, and also being clear about what resource we already have in the system that could support the development of that service anyway, and where the gap analysis would be.
Thank you. And Andrew, if you could let the board members know the dates of both of those, that would be really helpful outside of board. Thank you. I'm going to bring in Dydd first, please, and then Maynard.
You're on, Dydd.
Diolch, Chair. Thank you. My question is in regards to our long COVID numbers. Are you confident that GPs are actually referring patients with long COVID appropriately and identifying long COVID patients? And also, is there some confusion about the symptoms that patients present with in GP surgeries? And the second question is, how are these figures comparing nationally? And have we got pockets of patients within certain areas of our locations? Thank you.
Would you like me to answer that, Chair?
Please, Alison.
Yeah, I don't have the level of detail, Del, at my fingertips. I'm just back from leave today, but I can certainly look into getting the detail of the referral patterns and are they from specific practices and specific clusters, and have a look if we've got any gaps in service. I also haven't got access right now to the national figures, but I can do that and report back at a later date. What I can say is that comms has gone out to primary care more than once around the referral routes, and patients can be referred either by GPs or by any other healthcare professional. I think you'll see in the appendix from one of the meetings the referral rates, which have been fairly steady apart from the dip in August. And I have to say, I don't know whether that's because that's kind of 12 weeks after when we started to see rates coming down. So it could be that, it could just be the summer month, it could be an oddity. So we'll keep watching the rates. What I'm actually thinking, that what the referral criteria are, is that anybody who is 12 weeks post-COVID or post-suspected COVID with any lingering symptoms. So the service will see people with fatigue, with respiratory symptoms, shortness of breath, etc., etc. So it's fairly loose criteria, but I think what we may need to do, and I'll ask the team to action after the meeting, is to send another communication out via primary care, to primary care, and also on the global for staff as well, around what the referral routes are, because it should be a simple process, but I think a reminder may not hurt.
Bring in Steve. Oh, sorry, Della, if I could bring in Steve on the same. Pardon. If I could bring in Steve on the same issue.
Sorry, just say I think it's a really good question, because of course this is a relatively new phenomenon that medically is still trying to be understood. I just wonder, Alice, it might be helpful. You mentioned having a look at the kind of referral rates to see whether that gives us any indication about whether we've got consistent kind of thresholds across primary care, to bring that analysis to the exec team with, as you say, some proposals around further communication and so on. I think it's something we're going to have to keep pushing at, Derek, because I think there probably are people out there, would be our suspicion, who may benefit from this service, who don't even know they may have it, given the uncertainties around it. So Ali, if you can bring something back to exec team for a discussion, and then we can update the board through matters arising.
That's great.
Yeah, no problem.
If in exec you think it needs more detail to a committee,
yeah,
then we can agree that as well. Is that okay, Deborah? Do you have more?
Thank you, Chair. I think that's really, really helpful, because I think the communication though also needs to include the public, that actually they are open to actually speaking to their GPs about these lingering symptoms, because I think a lot of our patients in the community are there and just sitting there and not taking note of their symptoms. So actually any further communication with our public would be really useful as well, so that we've got a rounded picture, not just with our primary care colleagues.
I wonder if I may come in just to comment on that, because so far we've had 250 calls via the communication hub, and only this week I've been talking about a communication plan out to both our public and also internally within us to our staff as well. So we're looking, after we've done the board seminar around bringing the board up to speed, what we can actually put out to the public to enable them to access that level of specific advice and signposting as well.
I think it's a very, it's a really good point, that Della, that members of the public need to recognise that this is still a new thing, isn't it, for them, but they need to recognise that they can go and speak to either their GP or a healthcare professional about it, in order to get referred. So we're definitely looking to get some public comms out as well.
Thank you. And Maynard, do you want to come in on the same point?
It is a related point. Just noticed in the figures that were provided, there were some early referrals from social services, and I was just wondering whether we are still accepting referrals from social services, and in light of the previous conversation, whether we should include them in the communications as well.
Yeah, we certainly will. We will do that, Maynard. I think that's a good point as well. I guess at the early days when we did the comms and sent the comms out, then that it may be that that's fallen off in that particular sector, but absolutely, any health or social care professional can refer in.
Thank you. I think we have in the message bar, Lisa said she can give us an update on 22-131 in the action log.
Thank you, Chair. So I have received the information around carer referrals. So just for information for Carmarthenshire, there were 385 new referrals and 28 carers were referred for carer need assessment. In Ceredigion, it was 105 new referrals with 11 carers again being referred for needs assessment, and in Pembrokeshire, 93 referrals with 14 being made again for carers assessment.
Thank you, Lisa. Are there any other issues on the action log? Thank you, and can I just say thank you for the clarity as well of the action log, and the nature that it's really up to date, and today bringing it even more up to date. So thank you. If we now go on to the minutes of the corporate trustee meeting held on the 28th of July, any issues of accuracy in those minutes? Everyone happy to accept them as a true record? Thank you. And similarly, the minutes of the annual general meeting held on the 28th of July. Members happy to approve those minutes? Thank you. I'm just reading the board.
It just really go back to
COVID. Yeah. Okay, if Chantel's question is, are we planning to have specialist clinics in relation to long COVID-19 referrals? Can that also be reported back after the discussion of the executive, please? I think it's better if we have all the issues together.
I think it'd be timely to do a bit of an update on all the
absolutely. Yeah. Thank you very much.
Chair, sorry, can I just ask if members could possibly post questions in the chat rather than the Q&A, because otherwise we won't be able to see the chat to pick it up to make sure we can make sure members of the public can see it as well. Thank you.
So members of the public can see the chat bar?
We can't see the chat bar,
okay,
but we can't see the Q&A, so if any members are raising questions, we can't see them to answer them.
Thank you. And I will either read out the questions in the chat bar so that the members of the public can hear them, or I will ask the member who's written them to come in and ask the question themselves.
Yeah,
okay, more inclusive. Thank you. So the next item on the agenda is my report. As you can see, there's lots in there, so I'll just draw very briefly attention to some of the items. I think one of the big things is that throughout the summer, the Chief Executive, the Medical Director and the Executive Director and Planning and I and I have been meeting as many people as possible in groups across, in particular, Pembrokeshire, in relation to the programme business case, to listen to members of the public, to hear their views, and also to explain in detail the programme business case, which perhaps doesn't get reported in full in the media. And we've also included the community councils. We've been before the scrutiny committee from Pembrokeshire County Council and the third sector and Save Withybush campaign. And I'd like to thank Ewan for organising through his organisation Planet the One Voice meetings with the third sector and with the community councils. And as we said before, when we were considering the business case, we will continue to engage and we will continue to listen. If I could just draw attention also to the Ukrainian people who were cared for at Clangranog. Huge thank you to Joe McCarthy, our Acting Director of Public Health, and Ivion Evans, the Chief Executive of Ceredigion County Council. Everybody went beyond, and the care that they were given and the welcome really reinforced how we are a nation of fact sanctuary in Wales, and I thank everybody for that. The earth has now reverted back to its original use, but we did receive a letter this week from the First Minister and the Deputy First Minister thanking everybody for their exceptional dedication. In the report there are lots of references to where we are being first, for example, first to offer osteoporosis medicine and the pilot launch of Lumen. And I'd also like to offer the board's sincere condolences to those treasured colleagues of ours who passed away since our last board. That includes Lisa Lewis, a senior nurse manager in critical care, Muriel Watts, who was in the patient experience team in Withybush, and Denise Lewis, who was working as a cardiac rehabilitation clinical nurse in Bronglais. Again, in the report and at the end, you can see how incredibly well we have done by being shortlisted in so many awards. I think we should be very proud of that, particularly in the circumstances that we are working at the moment. How our teams are really, pushing the frontiers and really doing so incredibly well. And the Eisteddfod, thank you to Alwena and the team. We had a very successful week at the Eisteddfod, and again, it was an opportunity for us to engage with the members of the public and elected representatives and to listen and to share. So that's really my report. Any questions?
Chair, we've got a question from Paul Newman and Winston, both on Chair's action.
Thank you, Paul.
Thank you, Chair. Yes, in relation to the Chair's action and the plans for the home-based care service, obviously, as the paper outlines, the recruitment of this has perhaps not been as successful as we hoped, and we haven't managed to fill all of the posts, and we had a similar experience, I think, last year with the bridging service, which we introduced. At the risk of engaging in mention-itis, I previously mentioned when we talked about that, the issue of use of direct payments to people in order to enable them to purchase their own care in order to help people get out of hospital as soon as possible. Could we have some information, please, as to what efforts have been made to encourage the use of direct payments? Because as part of a solution, we're not going to find any one initiative that's going to solve this problem, and so as many tools as we've got that we can use in order to help get people home from hospital who don't need to be there, it seems to me the better.
Thanks, Paul. Can I bring in Jill?
Yes, thank you very much for that question, Paul, and you're absolutely right. We do need to have as many options available to us as possible. And direct payments do continue, of course, at this point to be available for those who are eligible for social care and are assessed according to that. At this point, as you're aware, direct payments for a healthcare provided service for somebody who has a primary healthcare need still is unlawful. But what has been now introduced as part of the new CHC framework is a commitment to now look at this in this next period of years with Welsh Government to see how direct payments can be made available for those who are eligible and have a primary health need. And there's reference there to independent user trusts. So Welsh Government have now set up in the last fortnight a working group to begin to look at it. But I just want to point out, which is quite important, around individuals' voice and control, which is a phrase we use within that CHC framework. Where somebody who has already been in receipt of direct payments for a social care need becomes eligible for continuing care and now is a primary health need, we will work with that individual and the local authority to ensure that for the component of their care that still relates to their social care needs, that direct payment can continue so that we don't compromise their ability to be as independent as possible. So that is still available, but the work has now started with Welsh Government to look at the provision of direct payments in the future for those who have a primary health need.
Could I just come back? I really had in mind those people who might need some domiciliary care type assistance, and looking at what we've got in our annual plan, which we're going to consider later, our ambitions in relation to the foundation economy and the desire for people to be cared for within their own home and to be as resilient and to build community resilience. It seems that the use of direct payments to help people with those sorts of needs should be promoted as much as possible, so, because that is also, which seems to be a barrier to people being able to leave hospital.
Absolutely, you're right. And the majority of individuals who require domiciliary care are really individuals who should be being managed through our social care services. Some do, of course, require nursing care. So I would absolutely expect that arrangement of direct payments to still be available to those individuals at this point. So what I can do, and we can provide the information outside of this meeting, is to provide an update across our 3 counties as to the numbers that are in receipt of direct payments and how our local authorities are working with individuals and with the Health Board to ensure that we are assessing individuals for all of the options that we have available to us. I'm happy to bring that back either to a different meeting or to an update to the board, Chair.
Thanks, Jill. I think what Paul is highlighting, as we've gone ahead with this enhanced bridging service, because of the acute demand for people who are currently in our hospital beds to be able to go home, that perhaps this should be also treated, well, not perhaps, this should be treated as a matter of a solution and urgency at this time, and talks with our local authority partners, rather than people who've had them and keep them. But this could be a way to help people leave hospital a lot quicker than is currently happening at the moment, which is having a huge knock-on effect, as we all know, on the front door and on admission and on ambulance times. And we've gone outside of our usual services to get the bridging service, and perhaps this is another way we can work together with our local authority partners to see if we can increase that provision. I think that's what you were trying to say, Paul. Yeah,
that should already be happening, Paul, so I will confirm that in terms of for new individuals accessing direct payments. So we will look at that.
Okay. Thank you. Winston.
Good morning, Bwrdd. My question is in relation to the enhanced bridging service. As you know, Chair, myself as chair of SRC and the chair of STAD discussed this before, and you have our unequivocal support for this. Slight concern I have is in relation to the paper sets out the financial impact for this year as being 476,000. My question is in relation to, well, what's going to be the full year effect of that? And do we have firm plans for how we anticipate that full year cost to be reconciled given our particular financial position at the moment?
Again, happy to answer that, Chair, and this was something, as you rightly set out there, Winston, that we discussed in that Chair's action conversation, because it's absolutely important that the board recognise that this is outside of our financial provision at this point. So we need to make sure that we understand how we're going to manage that going forward. There will still be the joint agreement between local authorities and the Health Board in terms of that ongoing commitment. So the full year impact for us will be circa 1.5 million that we'll need to be finding in terms of that commitment going forward. So I think from our perspective, it's about system efficiencies, and although it won't necessarily be cash out, what we would hope to do is to see savings within the system as we improve the efficiencies, get people out of hospital and improve that flow and that unlocking of our system, both at the front door and the back door. So that is the aim that we've got at this point, Winston, that this allows us to identify efficiencies that are not there at this point and help us to get our system working as it should be, in terms of also supporting our patients to access care in a more timely manner.
Thanks, Jim. Thanks, Winston. And if I could ask, where are we now with the recruitment? And for those members of the public who are looking at the board, it is all in the paper, the chair's action paper, but we've actually gone out to recruit in partnership with our local authority colleagues, extra people who can care for people in the community. And there are other measures in here so that we've created the equivalent of 127 beds in the community, which was part of our promise to Welsh Government and which was led by Steve across Wales. It's a short-term measure, but it's a very important measure so that people can go home, which is much safer than staying in hospital, and that enables other people to come in who need care. So just wondered where we were on the figures.
Yes, thank you. And the aim for Pembrokeshire was to recruit 20 whole-time equivalents. We've gone out twice now, and there have been 11 offers made, but that only equates to 5.4 whole-time equivalents. However, we've also got 12 out of our 15 apprentices secured as well. So there is still scope for further recruitment within Pembrokeshire. Carmarthenshire were a little bit behind in terms of their recruitment process, and they have now had 40 applications for their advert, but unfortunately 28 of those have had to be rejected due to immigration status. So 10 have been invited for interview, and that happened. It is happening yet, or happened yesterday. I don't know the outcome of that yet. So we're still a little bit behind where we would need to be. But I think the opportunity is there for us to go out to further recruitment, providing we get the legal agreement signed by our local authority colleagues, and that is still pending. So we do want that assurance so that we can move forward and get the sort of numbers that we need.
Thanks, Jill. And are we raising nationally the issue of the immigration status to see if the government can do anything with the UK government?
I can check that. We haven't done it specifically on this, but it will be a matter that's being picked up, to be honest, in terms of the whole of Wales. I do want to assure board members that this is part of an All Wales initiative as well, in terms of chief executives leading a piece of work on community capacity. And different health boards are doing slightly different things, but the issue around recruitment, immigration status, and also onboarding and training, etc., and also thinking about the ways we can work flexibly, as you raised in the chair's action point, Chair, to ensure that we get the capacity in place as far as possible and as quickly as possible. But I also do want to raise the important issue that I know is being addressed nationally. This is an issue not just for health, but it's an issue for social care as well. And I know that all ministers will be committed to this at this point in time to ensure that we have the type of workforce that we need to meet the demands that we already have within our system, let alone in the months to come. So this continues to be an agenda that's being seen and reported at a very high level. You know, we continue to work within that.
Thanks, Jim. I'm going to bring in Steve.
Yeah, thank you. And I think on the immigration status, with Jill's support, we're very happy to write to the Director General to set out our local challenges in relation to that, so that it's on their agenda. As you say, they probably know nationally, but I think we need to put more specific issues in. So Jill and I will write a letter to the Director General before the next meeting. And I think I met with Jill and Lisa yesterday to talk through the recruitment process, because I think at the last board meeting I was expressing some optimism that we may have a better outcome this time than previously, not least because we were offering substantive contracts. I think the first thing to say is those 12 integrated apprentices are the first in Wales, but I'm hoping we also get to the 15 number. We haven't given up on that yet. That's really positive for us. That's a long-term future. Maybe that doesn't help as much as fully substantive trained up staff in the short term. And I think the sense at the moment, and we do need to continue to work with our local authority colleagues and out in the recruitment process, is the recruitment market has significantly changed over the last few months, particularly in relation to the rates of pay. So Lisa's feeling in particular was there are other options which people can pick up, which maybe have better work-life balance and better pay rates. So I think we need another round of discussions with the local authorities about what we might do to address that issue. because as you say, 129 beds is really important to us.
Okay, thank you. And can I bring Lisa in on the overseas issue first? Then I'll bring Jill again. Lisa?
Thank you. Just to reassure you, for every applicant that we receive from overseas, if they meet the criteria for worker status, we are picking them up centrally from a recruitment point of view, so that we will bring them into our overseas recruitment process. So they won't be people lost to us as a health board. So we are managing that centrally.
Thanks, Lisa. Jill?
Thank you. I guess what I just wanted to finish with was a message to anybody who's watching this and may be interested in what we're saying around this type of opportunity, but may also have reservations because what they've understood previously around domiciliary care, dead end job, not a good experience. We want to make this a really good experience. And we're not just looking at pay and terms and conditions. It's about the team, it's about the communication, the education and the opportunity, and the ability to care for individuals and make a difference. And so I want anybody who feels that they may be interested but have some reservations or concerns to contact us, not wait for the next round of interviews, but just to find out more, because we want to make this a really good experience, not only for the patients that people care for, but also for the staff members that join us.
Absolutely, Jill. Thank you. And I'm sure many of us will come to you after this, and those members of the public, if we can get it out there, you know, into our communities and people that we know. And I'd just like to say a huge thank you. We have stepped into territory. We did it last winter, which isn't perhaps the NHS, but what we're focusing on is the care of people who we all serve. So thank you, you know, for doing this, and Steve, thank you for leading this in Wales. On that note, are the board happy to approve Chair's action and ratify the action undertaken on behalf of the board and support the work that I've been doing? Yeah, Val, thank you. We now goes on to the Chief Executive's report.
Thank you, Chair. I'll be relatively brief given the scale of the agenda we've got today, but just a couple of things I wanted to highlight. Firstly, as said in the Chair's report and mine, since our last meeting, of course, the sad passing of the Queen, I just wanted to add to the details that were in my paper a huge thanks, I think, on behalf of the board for all the people who in Howard are stepped up to react very quickly to that situation, the changes we needed to make to our services in the short term, and also the fact that Howard are played its very full part in all of the national arrangements in the morning period. So thank you, and I know the executive team themselves did a lot of that, so thank you for that. I'm looking also for board approval for the Withybush decant business justification case. I guess just noting the importance of this for the ongoing fire safety work on that site. I think a huge amount of progress has been made on that site in relation to that now, but also that whilst staffing will be a challenge, that this decant will also give us an opportunity into the medium term around additional space on that site should we need it, and that will support future flexibility. So I think a positive case to support there. There are two planning objectives which I've agreed with the acting Director of Public Health. We had a really rounded discussion about those ambitions, and I'm looking for ratification of those today to add to our planning process. And you will note the Public Service Ombudsman annual letter just to bring to the board's attention. I think some recognising the enormous challenges that our patients, our public and our staff have faced, some room for optimism there around our relationship with the Ombudsman's office. I'm also asking for ratification of the cardiovascular disease research and evaluation project. I think it's worth just highlighting that there's more work to do with our primary care colleagues as a key partner in this in relation to it, and Jill and I discussed that yesterday and ensuring that we picked that up. And finally, to approve the memorandum of understanding for the transfer, the much anticipated transfer of local public health teams into the health board. I'm really pleased that will be happening soon. I think just to highlight to the board that there is still, I think, a bit more work to do, which we have communicated to Public Health Wales in relation to the grant transfer. And there are some small risks related to depreciation, so we're going to work with Public Health Wales to ensure that that is fully addressed as part of the TP arrangements. Happy to take any questions.
Thank you, Steve. I bring in Judith and then Maynard.
Yeah, thank you. First of all, can I just say I'm really pleased to see the decant business case. There's been an awful lot of progress in relation to the fire safety And this will be a major step forward to ensure that the whole of Woody Bushes does meet all those requirements. My question relates to page 4 and the whole school approach. I'm just seeking assurance that health visitors and school nurses are linked into this. It doesn't say so explicitly, so I just wanted that assurance. And in terms of the new planning objectives, I just wondered which committee they would be feeding into.
On the first point, I might ask Joe to respond. And on the second one, I probably need to come back to you, Judith, on exactly which committee it'll go to. My guess would be at this stage it would be the Strategic Development Committee that does that work. But we'll confirm that as part of the update.
Yeah, absolutely. Thank you. Can you hear me okay?
Yes, thank you.
Brilliant. Fab. So yes, absolutely. School nurses are embedded in the whole school approach. They sit on the advisory groups for each of the local authority areas, and we also have a dedicated session now on the 15th of November to meet with our school nursing leads and to discuss both of these new planning objectives and ensure that they are comfortable with their role in them. And at that meeting we'll also have Angharad Jones from Aberystwyth University, because particularly around the One Health agenda, part of the role that she's had in setting up the nursing programme up in Aberystwyth University has been to ensure that she embeds interdisciplinary approaches there. So we'll cover all that off then. It's a good question around health visiting. We are fully engaged with our healthy preschools teams, and they are up to date on all this. But good question, Judith. Actually, we haven't fully engaged with our health visiting teams, so I'll take an action to ensure that they are also aware of this, because we've been focusing on our approaches in schools, but absolutely correct that everything starts earlier than that, doesn't it? So I'll take an action to speak to our health visiting teams as well.
Thank you, Chair.
Thanks, Joe. Thanks, Judith. Maynard.
Thank you, Chair. It's just a quick follow-up on the public health teams transfer. You've already said you're finalising the financial details, but how many staff are actually transferring to the health board?
Joe, you might have that detail to hand.
Yeah, I do. So there are 22. There are 22 spaces for staff, 20 of which are filled. So there'll be 20 staff transferring over. And can I? Apologies, can I just come back on Judith's last question as well, because I forgot to add, we are reporting in terms of the whole school approach, we are reporting through the Children and Young Persons board that sits under the RPB. We're planning to do that. Things are just getting up and running at the moment, so a report hasn't gone through there. There's also statutory reporting mechanisms through the local authority, but we were going to suggest, I think, that in terms of the health board we also report through ESTOD, but it's a discussion that needs to happen. But there's a couple of kind of formalised reporting mechanisms in place already for that work.
Okay, thank you very much. Thank you.
Chantel can't actually access the meeting, so is emailing questions in, and one of the questions is in the bar at the moment. I think it relates to the last report, but that's fine as well. And it's about the issue of accommodation for overseas staff who've joined us. This is likely to be a big factor as to whether they stay. I wonder if, Lisa, are you best placed to respond to that?
I certainly can. So accommodation is a factor for us across the organisation, particularly in Pembrokeshire at the moment. So we have changed our approach in terms of where our overseas nurses are going to work from this month, and we do have some new staff arriving any minute now within the organisation. So our new staff will be moving to Carmarthenshire, where we have got accommodation secured. And we are supporting individuals in terms of where they then choose to live once they have completed their training and then choose where they want to set up their home. Our rollout programme then will support us moving into Pembrokeshire. So we're working with our Director of Estates, who will link in with our local county councils to see what we can do to prepare estate for our overseas workers, staff, when they join us. So we are very minded that it is difficult. We're looking at some alternative solutions. It's a bit too early to comment on them yet, but it's very much in our minds and it's part of our plan.
And I think just to add to that, Lisa, we've also got some challenges in Ceredigion, which we'll be working on as well in a similar way.
Yes, at the moment we are accessing university accommodation. So we have interim measures in Ceredigion. It's then where they would move on to once they've decided they want to purchase their own home or rent their own home.
Thanks, Lisa. And if I could just raise an issue, Mandy and I did a patient safety visit to Llanelli last week, Prince Philip, and one of the overseas nurses had secured rented accommodation but had no furniture or anything and didn't raise that herself, but the staff wanted to support her. So I think if we could put that into our thinking as well, that would be really helpful. Thank you.
Yes.
Are there any other questions? No? Okay, are the board happy to accept all the recommendations in the Chief Executive's report? Many thanks. Next item on the agenda is the Audit and Risk Assurance Committee.
Thank you, Chair. Yes, the report is hopefully self-explanatory. The meeting was held on the 16th of August. You'll see there were three things which we've particularly drawn the board's attention to. One is a process issue in relation to the updates to the proposed changes to the Oracle financial system and the scheme of delegation. That's a sort of exercise in administration, but two substantive issues which I wanted to flag. The first is in relation to the concerns which are highlighted in relation to the WICIS system performance, and just to emphasise that this was a report which was received from Audit Wales, who've undertaken a further review of the WICIS rollout, and I highlight that particularly because I understand that the Health Board is under some pressure to roll out WICIS further within the organisation, and I think we need to be mindful of the issues which are highlighted in the Audit Wales report as we do so. And the second issue is in relation to how we're allocating COVID-related expenditure. We've taken £27 million into effectively our underlying deficit position, the cost pressure. That seems to be materially different to the way in which other health boards have perhaps treated that expenditure. Highlighted that again to Audit Wales, and they were going to look at that further, but I do wonder whether there's any further update on the position in relation to that, because the Health Board is clearly under pressure in relation to the extent of its overspend for this year, and that's partly driven by the way in which we're treating this expenditure.
Thanks, Paul. I think Hugh, you would like to come in?
David, diolch, and thanks, Paul, for the question. I'll respond to both the WICIS issue and the COVID expenditure issue. So if I start off with WICIS, clearly there are a number of challenges with that system, and until there is assurance that the system is fully fit for purpose, I don't see us expanding our use of that system in any other areas particularly. And that's a disappointment given the investment and effort that's been put into rolling out that system. And that's something I know that the Audit Committee are keeping a very close eye on. In terms of our COVID position, I'll come on to that somewhat as I go through the finance report, but the issue in terms of our differential treatment of our current pressures and our COVID legacy costs versus other health boards is something that has been raised with Audit Wales, with the Audit Committee, as Paul alluded to. I've got no specific update on that. It's something that we are keeping under active discussion through our Director of Finance peer group, but organisations have made their own decisions and views at this stage. We have, as I've said before, kind of wrapped our arms around the entirety of the legacy that we're seeing now, whereas others are saying that this is very much a legacy of COVID, and therefore there should be a separate funding stream for it. Ultimately, the take on the public purse isn't dissimilar across organisations, and that's something that I'm keeping an eye on really in terms of our differential take on the public purse to others, and I'm not seeing us being an outlier, particularly in that space. But it is a worry in terms of that differential treatment, and I await response from Audit Wales in their investigation.
Thank you. Are there any other questions or comments on the Audit Committee's report? I think for those members of the public who are watching, what the discussion just then was about how Howell are we presented our accounts in a different way from other health boards, in that instead of having a separate account for COVID costs, we've subsumed them into our deficit, which makes us look different on paper from the rest of Wales. But in actual fact, we're on par in relation to the rest of Wales. And I think that's important because it was picked up by the auditors in the Audit Committee. So just for clarity, so thank you. Thanks for that report, Paul. Over to the Quality, Safety and Experience Committee. Anna.
Thank you, Chair. The report is as it stands, and in the interest of brevity, I'll just highlight one issue which is referenced on page 4 of my report under matters to escalate to the board's attention, and that relates to our risk 1027, which is also covered on item 4.3 of today's board agenda, and it is about pressure for delivery of safe and high quality services in our emergency, unscheduled and emergency care pathway, including our integrated community services. We had a deep dive item on our agenda at our committee in August, and while the committee was assured that there are a wide range of initiatives, many very innovative, in place, without which the position might be worse still, the fact is that the residual risk is still at a very high level, in fact the highest red risk 25, and therefore simply for that reason alone we felt it was important for the board to be cited on this, and it may be something that you would prefer to pick up under item 4.3 when we consider the corporate risks, but I'll be guided by you on that, Chair. I don't know whether Andrew might be in a position to give us an update on that.
Thanks, Anna. If I could bring in Andrew.
Thank you, Chair. Thank you, Anna. I mean, I think as you say, the system continues to operate under significant pressure and strain. We highlighted there's a couple of papers later on as well in terms of the operational update and the winter plan for this year that are here for the board to review and in terms of the operational update note, but in terms of winter plan approve. I think we're continuing to the update report that you provide comments on the anxieties of staff, and I think we're continuing to hear that through our contact with frontline staff and clinicians around the pressures and the risks that they feel they're managing and holding every day. It certainly feels like, given that we're in September, the level of pressure certainly feels like where we've been, and even worse actually than some of our worst winters that we've had historically. And we talked earlier on around, therefore, the importance of some of those initiatives that we're taking and the building community capacity work in helping to unblock some of the flow and discharge out of the system, because undoubtedly the single biggest challenge we've got when we look at all the actions we're taking is the increasing length of stay and increasing bed day occupancy, which is really down to an inability to discharge in a timely fashion, the length of time it's taking some of those complex patients to work through, for us to be able to work those through the system with the pressure that the whole health and social care system is facing and dealing with at the moment. So I think the risk continues to be high. I think we continue to manage that in a very close and tight way. We're continuing to talk to staff on a regular basis to understand what it feels like and what it's like for them at the moment, and we'll continue to work with them as best we can to try and manage and mitigate the risks that we are certainly seeing. I think everybody accepts and recognises there are no easy or quick fixes to this, and it's more about making sure that we're listening to new ideas, really pushing and maximising the effort and benefit we can get from the plans we've got. Because again, I think everybody thinks the plans we've got around unscheduled care and emergency care are the right plans. It's making sure they can keep pace with and deliver the benefit realisation that we need to mitigate some of the other issues we're seeing across the system. Hope that helps answer the question.
Andrew. Welcome, Chantel. Nice to see you. Andrew, as you say, you know, we as a health board, our staff and our public are experiencing some real challenges in our health services at the moment, and there has been an increase of complaints that have come to me personally and to other members of the board. And I know there's a task and finish group which is looking at doing simple things really, as well as all the other things that we're doing to try and make the flow better through the hospitals, to improve the patient experience in A&E with at least comfier chairs, food, hydration. I just wonder where that is at the moment.
No, that task and finish week on Monday, he's popped up, so may want to come in as well. I think no, that task and finish group, that work is progressing. I believe they've been, certainly in the case of the A&E waiting room areas and making those more comfortable and trying to improve the experience, there have been conversations, and there's a procurement exercise and discussion ongoing at the moment around identifying suitable alternative seating. I think the real challenge and risk we need to be aware of in that is that every one of those new chairs we would put in would reduce our overall capacity in the waiting area from where we are at the moment. So there's possibly more work we need to do with that task and finish group as well, just in terms of thinking about how we would manage our sort of space and capacity as we head into winter, if we start to get there, or if we don't see an improvement, shall I say, in the length of time and delays we're seeing accessing our services at the front door. But I see Mandy and Phil have popped up, so they may want to come in on that as well from a professional perspective.
Thanks, Andrew.
Thank you, and yes, I will just add an extra comment. So the work that was started around the task and finish group that Andrew has mentioned has progressed. It is including a wide range of stakeholders, including our Arts in Health team. And certainly when I come onto the patient experience report, recognising the impact that the physical environment has on patients' experience and well-being can't be underestimated. One of the things that we potentially will benefit from is the opportunity to bid to Welsh Government for a small pot of money to help us manage improve our A&E environments across all of our A&E sites. And that is something I know that LDEG within our finance and capital planning team is working on currently with the task and finish group as well. But I do think it's really, really important to reiterate the point that Andrew has made, that for every comfortable item of seating, every recliner chair or whatever it is that we can actually put in there, we do have to significantly reduce the number of overall seating available. So we are going to have to manage this extremely carefully so that actually we don't make experience worse. But having access to basic fluid, the hydration, snacks whilst people are waiting, information availability so that people know what to expect whilst they're waiting, looking at how we support members of our population to use our services effectively in terms of signposting to alternatives is going to be critical to how we pull this all together as well.
Thanks, Mandy. And does the group include us able to purchase quickly blankets and pillows?
So the blankets and pillows shouldn't be an issue, but I'll pick that up straight away after this meeting, because I haven't heard that is a particular issue, and certainly working with our laundry department, as I say, that shouldn't be a matter of any delay at all, but I will pick that up straight after the board meeting.
Thanks, Mandy, because I have had complaints come in directly to me of people being cold, so thank you. Phil.
Thank you, Chair. So a couple of points. One is that there's a huge amount of action being taken around improving the flow. because the A&E in some respects isn't the issue, it's the system around it. And those actions that you've highlighted and Mandy and Andrew have highlighted around trying to improve the patient experience whilst people are waiting in our A&Es are really important. I suppose I visited A&E in Withybush on Tuesday, met staff, talked to patients there, and it's really challenging, the situation for patients who are waiting far too long in our A&Es, as they are across the country, I know, but you know, in the end it is a really tough experience for people, and I apologised to the patients that I saw there, but also can only apologise to other members of the public who are also experiencing that on a daily basis, and what all those actions we're taking around improving this patient experience in the A&E, where there's too many patients for the area we have, we shouldn't forget that we really need to improve that. So whatever we do, it only improves the patient experience. It doesn't mitigate a situation that we just mustn't normalise, and I think that's what our staff are telling us. So for the patients, it's their once in a lifetime experience. For the staff, that they're sort of seeing it each day, and we are meeting with our A&E staff, myself, Mandy and Andrew, to look at what practical actions, however small, we can take to improve things at the moment. And of course we have the winter coming, so it is a concerning situation, which is why the risk score is as it is.
Yeah. Thanks, Phil. Totally agree. As you say, we can do as much as we can, listening to staff and patients, the simple things. But I know we're doing so much to try and prevent people coming into A&E and enable people to go home so that beds are available, which takes us back to the community care capacity building and our need to recruit. But thank you. Adele, if you want to come in.
Diolch, Chair. It's just a question really about our public and information to our public about choosing well, how self-care can happen as well, but what to expect when they go to A&E, but what is acceptable to go to A&E and where they can seek help appropriately in the community. So what's our communication strategy like going forward to enable our public to be aware of what we can and what we can't do? Thank you.
Perhaps I can answer in part some of that question. So one of the things that we do need to make sure that we do is ensure that our communication strategy for our population is clear and timely. Certainly when we get into difficulties within our departments, because of the volume of activity that we're trying to address, we do put out notices to the public and ask them to consider alternative options. We have a wide range of services available across the footprint that is Hywel Dda, from community pharmacists looking at how our minor injury units with our extremely experienced nursing workforce can support members of the public as well. But I think revisiting and ensuring that our comms strategy is really clear, that helps people choose the best route to seeking help and support, is going to be critical for us, particularly during the forthcoming winter period.
Andy, and that includes also asking, reminding people the hospitals are not safe places for their loved ones to be, and if they're ready to leave, then to please take them home or take them to their home, because we need the beds for others who need them desperately. So thank you.
I think that's a critical, if I may, Maria, that's an absolutely key message for us in terms of when people are medically fit to leave hospital, we need to find ways in which we can support people to actually leave in as timely a way as possible, and really helping our population to understand that actually staying in hospital for even a day longer contributes to deconditioning. So it actually contributes to people not being able to function as best they can. So it is really, really important, and that is something we're going to have to be clear about in how we communicate with families, in particular where the option to go home is available, and that we do that at the point of admission. So that's something again that we're also looking at, what more can we do to help people.
Yeah, absolutely. And as we know, most people want to go home and don't want to be in hospital. Chantel wishes to ask a question. Do we have data as to the reasons for attendance at A&E?
Do you want me to pick that one up, Chair? Yes, we do. And our 6 goals plan and response to the 6 goals of urgent emergency care is very much based on an analysis of that data and information. So we've identified through that the various groups of or cohorts of patients that we think could be managed via alternative pathways and don't need to attend a full ED department, and the plans we've got in place are trying to make sure we've got the service model that supports those alternative flows. I think the key change that we've seen in the last 6 to 9 months in relation to urgent emergency care is that we're seeing a higher number of self-presenters than we've seen previously, and they're presenting with a higher level of acuity. So there has been a change in the nature of what's presenting. Now, I suspect and feel that some of that is related to the challenges that the ambulance service have had in being able to respond to all patients in the community because of some of the delays that the system is imposing on that in terms of their response and our inability to offload and get because of the flow challenges we've been talking about. But there is, yes, we've got lots of analysis of the data and the issues, and we've used that very much to inform the basis of both our immediate plans for this winter, but also our more, if you like, our more transformational plans for urgent emergency care as well.
Thank you, Andrew. Any other questions on the Policy and Safety Committee? I've just got 2 quick ones. One is the Director of Mental Health and Learning Disabilities is undertaking a piece of work to understand why the Health Board's element of Tier 4 pathway is taking longer in comparison to other boards. And the other one is on the mortality review model framework. It's been embedded successfully in Prince Philip, Bronglais and Glangwili. I just wanted to know whether it's also been embedded successfully in Withybush.
So if I may come in on the issue around the Tier 4 particular matter that was discussed at the committee meeting. Liz Carroll, our Director of Mental Health Services, is actually looking to explore that as part of the wider approach to how we're accessing and utilising specialist services, because the issue around step down, we need to fully understand the pathway to ensure that patients aren't waiting any longer than absolutely necessary in a specialist bed when they could actually be pulled back to local services. So there will be some further information that comes back to a quality committee when we're in a position to be able to have done the deep dive work that Liz and her team are working through.
Thanks, Mandy. Phil?
Yes, Chair. My understanding was it has been implemented in Withybush and that there were some minor matters to resolve at Glangwili. But let me check on that and come back to the board on that.
Maybe an omission on paper. Thanks, Phil.
Yeah.
Okay, thank you, Anna. Thank you very much for your report. And if we can now go on to the update on the annual plan, and that's Lee.
Morning, thank you, Chair. So yeah, Hugh and I will do a bit of double act on this, but as a way of introduction, first of all, so members will be aware that we brought a series of papers to board, regularly updating on our plan for this year and of course for the next 3 years. And that we remain unable to submit an IMTP to Welsh Government in the main due to the financial challenges relating to some of the pressures that we've talked about already. In the last board in in the board in July. We updated an annual plan, and that was presented to the board with an end of year forecast of 62 million, which you'll recall Welsh Government have advised is unacceptable. As a consequence, we've set out a number of steps, or a number of steps were set out at the board meeting by Steve, the Chief Executive, to bring back to this meeting, and the paper sets out those actions that we've taken, and in particular focus on the current operational financial pressures, the target operating model work that we've been pursuing, and then any further in-year actions that we can take to address the challenge we're facing this year. There's also a short update in the paper on our current thinking in relation to next year's plan, or the development of next year's plan, which we'll bring back for a further update to November board. So I'll pause there and then hand over to Hugh, if that's okay, Chair.
Thank you, Lee.
Lee, John, thank you, Chair. I'd just like to take you through some of the key actions that we are taking, and how the operational challenges that we're experiencing, that Andrew alluded to earlier, are manifesting themselves in the financial position, hence the response that we're putting in place here. If I start off with some of the challenges on complex patients and the challenges in discharging complex patients and the interface between health and social care, we are forecasting this year that will contribute about £10.6 million to our deficit. And if I add on to that the challenges in broader inflow in hospital in terms of medically fit patients, that's a further challenge of 15.5 million on our bed base. And of course that then drives the demand on our nursing staff, which means that we are spending a further premium on agency staff of 7.5 million. So that's 33.6 million pounds of our deficit that is directly linked to the operational challenges on flow and discharge that Andrew alluded to. So the target operating model work, which is highlighted on page 4 in transforming urgent and emergency care, and the integrated localities plan, directly addresses those issues, or seeks to directly address those challenges. Clearly, in and of themselves, they may not deliver the benefit that I alluded to in terms of the cost, but they will be a significant contributor to a way out of the challenge we're facing. The third target operating model challenge that's included there is long-term care within mental health and learning disabilities. And there's a further £10 million of cost that we're incurring currently that represents a challenge, and this is a modelling challenge that we've understood, a disproportionately higher level of 50-50 funding splits between us and social care for mental health and LD packages of care. That's something that needs further work and further investigation to see whether there is an opportunity for the health board there. So that addresses the target operating model on page 4. I'll then just move on briefly, Chair, to the further in-year actions that are included on page 8. And there are 4 further actions that are being outlined there. I mentioned the first one in terms of the £7.5 million that we are spending on nurse agency in totality. One of the actions we're looking at is on the supply side, seeing whether we can enhance the supply of nursing staff within the system. That means that we can at least address the off-contract use of agency, which is a particularly expensive way of bringing staff in. There's a further challenge that we have in terms of our use of medical agency staff. We spend about 3.8 million in terms of a medical agency premium across the health board, which again is a contributor to our deficit. And that figure would be higher were it not for vacancies that we're not able to fill, even with agency staff. So a further piece of work to understand particularly those very expensive sources of agency within the medical workforce. The third element then is developing an alternative care unit where patients which are medically optimised, I mentioned £15.5 million worth of cost that we're incurring there, where we can look at a more optimal solution to the medically optimised patients with a therapy-led workforce and a different workforce model that will allow us to look after those patients differently. And the last element is addressing the sustainability of the family liaison officers. This has been a workforce that's been phenomenally well received by our patients, staff and families, and the cost incurred by us is about £1 million in relation to the flows. The flows have a very important role, but getting a sustainable workforce model for the flows is a challenge for us across our system. By linking the flows in with the alternative care unit, that provides us with an opportunity, I think, for a more sustainable model going forward. So those are the further in-year actions that are being taken. With all of these, as it currently stands, we have not costed in a benefit to reduce our financial deficit because we don't have sufficient assurance that the dials are changing as yet. And further work needs to happen to bring that assurance to bear. I very much hope that by the time we come back in November, we can start to see how these schemes will erode that deficit and bring it down. Chair, with that, happy to open to questions.
Thanks, Hugh, and thank you, Lee. Any questions?
Just coming on the first point that Hugh made, which I think was really important. Hugh and I agreed yesterday that we'll bring a written update back to board in November as part of the update, Hugh, in relation to the costs we're carrying for the challenges of discharge. I think it's important that we do set out the impact that's having on our deficit. More than 50% of our deficit linked to that. That is not to blame any other part of the system, but simply to put it in the public domain about what it is that we're carrying here. So we know the challenges that there are in domiciliary care and social work. And of course, it's fair to say it isn't entirely to do with domiciliary care and social work. There are things in our own gift as well. But I do think we need to be clear as possible about the system impact, the cost impact of the challenges that we're facing with discharging complex people back into their homes. So we'll bring that back for a full update at the next meeting.
Thank you. Questions from board members?
Anna Lewis, Chair.
Anna, would you like to come in?
And Chantal.
And then Chantal.
Thanks, Chair. Two questions, if I may, about the alternative care unit pilot. The first is, how many beds are we planning to open within that pilot? And importantly, how are we going to enable flow through those beds rather than run the risk that it becomes a new bottleneck?
If you're happy for me to come in and respond to that, Chair. About 5 weeks ago, we started the discussion around the alternative care unit, and I had hoped that we would at least be up and running by the end of this week, rather ambitiously, I have to say. However, we've had to take a step backwards to be able to go forwards, and we've changed the area in which we're going to potentially be operating this model out of. The aim at the moment is 15 beds. And we are currently working up the staffing model. We've had several iterations of the staffing model to be able to support those 15 beds. It's believed that at any given point, and this is just for Glangwili, for the Carmarthenshire system at this moment in time, because obviously this is a very different model from anything we've run before, and we do need to test. What I will say, and apologies for going on a little bit, the issue about the bottleneck is something that I've been really clear about. This has to fit in with our overall approach to urgent and emergency care and the programme that we're driving, and looking at how it links in with frailty, how it works with SDEC, how it works with the front door, so that we can actually make sure that the people who go into this particular clinical area are ready to go. They are ready to leave hospital, and they will meet a very clear criteria before they go into that particular area, so that there is a pull through the area, rather than it's just somewhere where somebody goes to sit to wait for an inordinate amount of time. These will be people who are predominantly, they would normally be able to go home to their own home. They might be waiting to go into a residential care home. And that's really important to understand in the context of the skill mix and the workforce that we put around this particular unit. So working from the community end with the integrated care management teams and looking at how we work with our discharge liaison, it is expected that we will have a constant list of people who will be suitable, so that the minute a bed becomes available in that area, there is already a cohort of individuals who will be able to go and populate that bed. And it is expected that that would be a flow through approach. So that's something that we're currently working on. The other thing that I would say is that to make sure that we learn and we optimise the learning associated with this very different model, I'm wrapping around quality improvement methodology so that there is a constant 24-hour review every day of what worked well, what needs to change to improve the flow, and so that we can turn that learning through PDSA cycles very rapidly back into different ways of working, so that it's not testing it, waiting and bringing it back. So I hope that helps address the queries.
Thanks, Mandy, and I'm going to bring Steve in on the same point.
It's just here, thanks, Mandy. And I had the opportunity of meeting Olwen this morning in the corridor here at Glangwilly, the lead nurse for Carmarthenshire, who described some of that. As always with these things, they're a simple idea, but as Mandy said, they're quite complex to get right in order to avoid the sort of risks that Anna's set out, because it is still a hospital ward, and that means there does need to be certain requirements around medical oversight. So getting that right so we don't end up really with just another bottleneck in the system is going to be really key. But the team working really hard to get that working. And of course, once we've got that template, then being able to roll that out would be really important. I think the other point I wanted to make is that this is not really about addressing flow issues, because actually it's about how we organise ourselves within the hospital. It links back to the concerns of the Quality and Safety Committee about risk that we have in the system. And actually by doing this properly, it should be able to allow us to reduce somewhat the risk, because the staffing model is different and allows us to use our registered nurses and particularly our registered nurses, not just our registered nurses, in the best way possible across the site. So it's just to bear that in mind, that it probably won't have huge benefits for flow, although Mandy might correct me.
Fingers crossed. And Mandy, it's a simple question, but I expect the unit will have people, enable them to be dressed, to eat together, activities, so they don't, you know, deteriorate while they're in there.
Absolutely. So I know there has been concern about whether we lose any beds. One of the areas that we are, I'm absolutely committed to, is that within that particular unit, there will be a day room type environment. The expectation is people will be up dressed as they would in their own home, and that they are supported to have a really active and meaningful day. Part of the staffing model is looking at what we do to make sure that people maintain their optimum functioning whilst they are waiting to be discharged out of that or transferred out of that unit. One of the things, if I may, is also looking at how we can make sure that if they are going to their own home, how do we prepare relatives and support them to be prepared for that patient going back into the home environment. So that is something we're going to have to work through as well. We're also looking at how we can support and deploy armed technology. That sounds a little bit frightening, but it's nothing to be worried about. But it's actually looking at how we utilise remote monitoring that may well be deployed for somebody who's going into their own home. So that's also something that we're looking at as well. So this is really, really testing all sorts of different opportunities and things that I'd have to be really frank are outside some people's comfort zone. And certainly the issue around medical oversight is actually one more of escalation if somebody does become unwell whilst they're waiting, and that pathway back into the acute care area as well. So there's so much that's actually being worked through, as you've alluded to, Steve, about the complexity of what sounds like a really simple scheme, but hopefully that addresses that question.
Well done, Mandy, well done. I've got a number of people who wish to ask questions. I'm going to bring in Chantel, then Judith, then Winston, then Dellen.
Yes, thank you, Chair. I just wanted to ask a much broader question. I can see that there are lots of challenges into the system, and I just wanted to ask the question around how does the rising cost in energy, the falling pound, the mini budget and everything, how does that impact on us managing the deficit and putting in all of these measures to manage flow through the system?
Hugh?
Thank you, Chair. Yes, clearly there is a knock-on impact, and difficult to discern which what the driver of inflationary pressures may be, because they fall differentially in different parts of the supply chain. But we are seeing, for instance, significant pressure within medicines management, in particularly the cost per item growth that is being experienced across Wales. And our data in primary care prescribing is about 2 months out of date, because of the way in which the system operates nationally. But we are seeing already significant pressures coming through there that may well push on into the rest of the year. So that's certainly an area of concern. Clearly, energy costs has been a concern. The UK government's announcement over the mitigation of that risk is helpful. From our perspective, as a health board, that doesn't directly benefit us, because we were already anticipating support from Welsh Government to address that challenge. So this will effectively mitigate some of that risk nationally across Wales. And the other thing just to highlight, of course, is the Chancellor's announcement last week around the reversal of the national insurance increase. That again doesn't directly affect us this year, because we were counting, or the risk for that had been covered by government for us, by Welsh Government. So some of these differentially impacting us directly versus the general challenge that Welsh Government is experiencing.
But does that mean we will be able to manage within that envelope of the deficit, though? Or are we looking to having an increase in the deficit?
Chair, I think absolutely, Chantal, that there is a risk based on that ongoing inflationary pressure that we're seeing. So at the moment, all I can say is that that is a risk that we are managing within the overall quantum.
Thank you. Thank you very much for that. Thanks.
Probably fair to say we face as much uncertainty as everybody in the general public. Judith?
Yeah, I just wanted to ask a question, it's probably for Mandy. I understand that if someone is admitted for an acute incident from a care home or a nursing home, we are not transferring them straight back there when they are able to be discharged. That there's a whole process of assessment. Isn't that accurate, or is that in it? Or, and if it is there anything we're doing about that?
So Jill may want to come in and offer a comment on this, but certainly there are challenges in us being able to get patients back to care and nursing homes once they've been into our hospitals, and depending upon the length of stay that they've had with us, will depend upon the speed at which we can actually get them back into that facility. But it may be, Jill may want to comment specifically because she's much closer to the issues around nursing and residential care.
Thank you, Chair, and thank you, Jill, for the question. Yes, I mean, we have had a number of individuals who've been admitted in ambulance, and we've been able to turn those around. They've been assessed on the ambulance or in our AMAU, and we have returned them back to that care home. If they're admitted, there is a likelihood that their needs may increase during that period of time. Now, it should be that we discharge to recover and assess, so they can go back for that further assessment. But where their needs have significantly changed, there is sometimes a challenge then in terms of care homes accepting them back into that facility. I had to chair an event on Monday. It was a very good event actually with care homes. There were about 60 people at that event, and we did raise the issues of the importance of the care home sector within our whole system. Very much part of our whole process, our family really, in terms of the way in which we provide care. And as well as reflecting on the challenges they face themselves as organisations, it was really important also to raise the challenges we're facing around what I'm perceiving to be a change in the threshold of acceptance as well, because we are seeing that more care homes will now reject an application from an individual to go into care because their needs are significantly higher than they feel they can staff. Where it has been someone's own home, that's a really challenging issue, Judith, and we'll do everything that we can to work with that care home to see what additional support is required to ensure that individual can go back to that home. It may be that it's entirely inappropriate where it's been a residential care home and they require now significant amount of nursing care that can't be provided through community services. It could be that there does need to be a change, but that can hold up the system.
I won't prolong it now, but I just find that actually unacceptable, having been in a situation with relatives that a care home saw that as their home, so they took them back. It just feels wrong, actually.
I would prefer that,
yeah, maybe not prolong now.
And I think it's another time, it might be a board seminar. I think it would be worth having a much greater understanding. We've done a lot on domiciliary care. I think a feature perhaps on our care homes, residential and nursing homes, but again, it'd be something the board might be interested in exploring further, because it's another part of the system we need to unlock.
I agree. I think we've very cited on all the initiatives to prevent people coming into hospital. I think a seminar on discharge to include all that, I think would be really useful. Okay, thank you. Thanks, Judith. Winston.
Thank you, Chair. Yeah, my question is in relation to the question I asked earlier, actually, which is the enhanced bridging service. I noticed on page 6 of the annual plan, we make reference to it, which is good, because I think the this whole section shows that we're doing a huge amount of initiatives to reduce the number of beds. So my question is, currently it says on page 6 that the financial benefit anticipated in this year for the enhanced bridging service to be between 0.3 and 0.5 million this year, and they gave them 1.2 million pounds for the forthcoming year. I wondered whether that estimate is based upon the net impact, in other words, takes account of the costs we're incurring this year of 475,000 and the full year of 1.5, or does that just show what the anticipated savings are going to be? That's the first part of it. Second part of it, when we estimate those savings, are we assuming that they're savings based on people in post, or the enhanced costs of agency, nursing, etc., to cover our vacancies on some of our wards?
Can I bring in Hugh?
Yeah, thank you, and thank you, Winston. And that is the gross saving. So therefore, what we're saying is that we would anticipate that this covers itself broadly with a net cost pressure that's about 200,000-300,000 for a full year effect. We have not been particularly. I recognise that there is an opportunity here for a greater benefit. However, with the pressures that we're currently experiencing within acute services, I would not be particularly ambitious in the level of cash out opportunity. It is mainly going to be consuming its own smoke, I think, and giving some slack within the system at best.
Thank you, Hugh. I just want to confirm something there. So what we're saying is that if demand remains steady, then we could make a benefit of those 52 beds in Carmarthenshire and 38 beds in Pembrokeshire. But obviously we know that demand is fluctuating, probably on the up. So we're saying that it gives us more capacity to respond. Is that right?
Sorry, I didn't.
So sorry, Chair. It supports the broader stability of the system. Yes.
And just one last thing, in terms of the risks associated with it, then is that mainly demand based and recruitment based?
Yes, currently in terms of the recruitment challenges, we've already spoken about those briefly, but yes, there is a real recruitment challenge here. I think it speaks to a broader challenge that we've got now across all services and across kind of all grades, really, that recruitment is becoming a very real challenge for us.
Okay, thanks very much. Thank you.
Thanks, Winston. Thanks, Hugh. Deleth and then Barbara.
Thank you, Chair. Going back really to Mandy's point, Mandy nearly answered my question in regards to the ACUs in Glangwili. I'm just asking if there would be some consideration to further family member involvement in the patient's care to actually identify further needs that they might need on discharge, or that families can actually liaise much more appropriately with the nursing staff and the care staff on that unit. So really it's thinking about more family involvement in their care.
Yes, if I can come back on that, because we're still working at the model, really understanding the opportunities that family engagement and involvement can offer is something that we will certainly take forward. I can't say at this moment exactly what that will look like, but in my head, I'm already asking if there's opportunity either to provide training to people, to support them to care for their loved one at home. There certainly will be opportunities around how to use equipment, if there's equipment that's required in the home. So I think it's a case of watch this space, and I think as we get into this, we'll be able to explain and explore even greater opportunities than we're first anticipating.
Thank you, Mandy. Barbara.
Yes, I'll make this as brief as possible. My question is on the flows, which is sort of quite an outright question really to ask, are they going to continue? And my reasoning for that is really how well they would support patient experience. Certainly from the feedback we have had is that it adds a lot of value to that patient experience. And I think indirectly, although everything can't be measured or is not measurable in pounds and pence, the impact on staff in time is likely to be of a benefit, but also that liaison with families may just encourage earlier discharge, etc. So I think on the positivity of patient experience, I would hope, or one would hope, that they would continue.
Thanks, Barbara. Mandy, do you want to take this?
Yes, please, if I may. So there's been an evaluation exercise being undertaken together with the values-based healthcare team and supported through through Mark Bolin, actually, within the finance team as well, to look at how do we articulate the value added as a consequence of this particular role. And I think what has happened, we introduced the role at a point in COVID at the very start to actually maintain communication and help us ensure that patients were connected in with families and loved ones. As the pandemic has developed, and we are hopefully coming out the other side because COVID hasn't gone away yet, their role has morphed and changed, I think it's fair to say, as we've learned about the opportunities that the role can undertake. So I'm expecting to receive next week the outcome of the evaluation report. I'm looking at what is the value added that isn't just about cash out, for want of a better expression, but actually with some of the other systems that have been introduced. So the Civica patient experience system, the symbiotic system that we're introducing across the organisation for something like meal ordering. Are there roles that they are now undertaking that perhaps aren't as recognised as they were before? That said, we've got to make sure that we're deploying our workforce to maximum effect and that we can actually afford to maintain the workforce that we've got. And part of the exercise that I've been trying to work through is, if as part of the work we're doing in terms of team around the patient, is there scope to build in the role of the flow within the funded establishment within the clinical areas? I'd have to say, as I sit here now, that is proving a little more challenging than I had first hoped. But that is, I haven't drawn the line on it yet, and certainly there are continuing conversations about how we look at the flows. We have got fewer than we had, obviously, at the start of the pandemic, and therefore costs associated with that are coming down as a natural progression. But certainly in areas such as our emergency departments, where that pivotal point of communication with loved ones is so key, that is an area that I would certainly be looking to make sure that we can continue that role, but certainly as well with the alternative care model that we're developing, as Hugh, the finance director, has indicated. I'm also looking at how do we maximise the opportunity of utilising the flow role and experience in that environment as well.
If I could just quickly add something in there, the positiveness to carers as well, having that liaison person to be able to recognise those carers' needs, but also recognising what care they may need for discharge. Often they're a category or a group of people that actually not always heard. But thank you for your response. Thank you.
Thank you very much, Barbara, and thank you, Mandy. So if we move on to the recommendation. Before the recommendation, what we have is that the board reminded that on the 31st of March 2022, we approved a draft 3-year plan for onward submission to the Welsh Government. We weren't in a position to approve an IMTP as full assurance could not be provided in respect of achieving financial balance over 3 years, but we committed to continue to work towards this Q1 of the current financial year. At this stage, following discussion in July 22 board meeting, the board remains in a position where it does not have sufficient assurance to approve an IMTP or an acceptable annual plan. And we are continuing to work towards the planning objectives, which were also approved at the board meeting on March the 31st, 2022. However, the operational drivers to our financial position are leading Welsh Government to view the Health Board's current financial position as being unacceptable. If I may add to that, as the chair of the board, although we haven't been able to approve the plan due to the financial deficit, we do have a plan and we are working to deliver that plan. So furthermore, the board is asked to approve the following. And I won't read out the rest of the recommendations because it's before you, just to confirm that the board's happy to approve the recommendation. Thank you. And if I can just go back to the question in relation to the mortality review in Withybush, Phil has put in the message bar that has been fully implemented. So thank you, Phil. We'll now go on to the improving patient experience report, and that's Mandy.
Thank you, Chair. Yes, I'd like to start by saying a big thank you to the lady Alison, who hopefully you've seen the YouTube story that's been provided within the report. It's always very pleasing when individuals want to share their story with us, whether it's positive or negative, because it's such a key point in how we go about learning about the patient experience that our population have of the services and the wide range of services that we provide. And I will come back to the whole approach about storytelling shortly. I think what's really important is to recognise that we have had just over 2,500 people provide us with pieces of feedback during the 2 months of June to July, both through the All Wales survey and also the FFT approach, that Friends and Family approach that we use within the organisation. And whilst the overall positivity rate for the feedback that we received is lower than we saw in 21-22, I think we need to think about the context, but importantly, we've still got 83 and 81% of people who use our services expressing positive feedback. That said, for every piece of feedback that we receive that is not so positive, we obviously try to provide feedback directly to the individual, but also importantly to the staff that are involved in delivering that care and service. Our complaints, 427, have been called out in the report for the period, predominantly areas, and I think these come as no surprise in terms of accident and emergency, ophthalmology, urology, orthopaedics, access to GP surgeries, medicine and neurophysiology. I'm pleased to say that we are taking a really proactive approach in trying to make sure that wherever possible we achieve early resolution, and by that making sure that we make proactive contact with individuals who have brought matters to our attention and actually resolving the issues before it escalates into the formal putting things right process. The one thing that I would call out is that actually in terms of our response rate, we aim to get as many of our complaints responded to within the shortest period of time. So ideally 30 days. However, given the complexity of the complaints and the range of services that are contained within complaints that we receive from members of the public and patients who have used our services, we aim to make sure that we get the closure within 6 months. That may sound a very long time, but throughout that period, we are endeavouring to keep in touch with families and the patients directly. The way in which we go about keeping in touch is driven by the way in which the individual has asked for us to maintain that contact. You will see on page 6, and you know, as the Director of Nursing, it always saddens me when I see negative comments about the nursing workforce, but you will see we haven't shied away from sharing that feedback, and it highlights the negative comments regarding nursing staff communication being rude, and not perhaps communicating in the way that we would expect them to communicate, particularly in front of patients and their families. I do want to reassure both the public and the board that I've already taken steps to address this. And at my recent, in fact, last week, senior nurse midwifery team meeting, I actually read out some accounts that have covered off a range of issues. And furthermore, I've made it very clear that we are revisiting the standards professionally that we aspire to deliver as an organisation. On page 12 of 30, you'll see within the report there is reference to the sensitivity relating to the approach by some of our medics, and obviously the issue around particularly breaking bad news has been raised with us in a number of complaints. What I would say is that wherever feedback is received about whatever professional group, that feedback is always provided back to the senior leadership team. And in the case of some of the feedback about our doctors in particular, that's been dealt with by our clinical leads. And I'd have to say that has been very proactively received and managed. So going back to the issue, as I said at the start, about the use of storytelling, that is such a powerful way of helping our staff, no matter who they are, understanding the impact that their approach, their manner, their communication has on patients and their families. And that is something that we're endeavouring to do increasingly, which is why it's really important that we encourage our patients to share their stories with us. We're also looking at using the customer care programme that certainly Lisa's team has taken forward, the Making the Difference programme, and that is actually beginning to make a difference, and that is really important. The one area that I'm really keen that we do some further exploration on is around empathy, and particularly that element about breaking bad news. And how do we support staff to experience and walk in the shoes of the patients and the families that sometimes are receiving adverse information or things that will affect the way in which they go about living their day-to-day lives. So that is something that Louise, my Assistant Director for Complaints and Legal Services, is actually working on. And we're going to look to see what we can do in perhaps a little more innovative way. And then finally, in terms of complaints handling, the team have been asked to review and have reviewed the way in which they're supporting complaints handling, because that has also been called out through the Public Service Ombudsman's report that we had several cases where complaints handling could have been managed better. But actually the issue there is particularly around access, timely access for clinicians to medical records so that they can actually formulate an informed response. At the moment, it takes well in excess of 2 weeks to obtain a record, and actually then there is the issue about how we scan it. But that's something again that we're looking to try and do a further piece of work on. I'm going to pause there, and I'm more than happy to take any questions.
Many thanks, Mandy. I'm going to bring in Chantel and then Barbara.
Thanks, Mandy, for this very comprehensive report, and then I very much enjoyed looking at the data that you've produced there. But I was just wondering on a broader question around whether the board receives data around training, because clearly that requires some training of staff, and whether we have that data. and also whether the management of complaints by patients, whether that features as part and parcel of the PDR or the appraisal scheme for ward managers, because some of those will be obviously ward based, and whether we are asking our ward managers to ensure that the staff that work as part and parcel of that ward, I recognise the challenging situations in the landscape, but whether we make that as part and parcel of their appraisal scheme.
So if I start by answering the second question first, and I'm sure Lisa may want to comment on the role of the People Committee around the training data that's made available through that committee. But certainly in terms of feedback to our staff, one mechanism, not so much through the PADR, although I do know that that is discussed as part of the individual performance review process with all of our staff, and certainly for our medical colleagues looking at how they utilise feedback as part of their appraisal and revalidation, and likewise nurses as well. In the nurse staffing levels review work that I undertake formally on a 6-monthly basis, but obviously I do it in between as well when I've got particular hotspots or areas that I'm concerned about, we actually explore training compliance. We look at both mandatory and any specialist training that's required. We look at complaints, we look at incidents, and we actually make sure that we utilise all the data that's available relating to that particular ward area to help inform decisions around staffing. And if we are seeing particular complaints or themes emerging, then there is a specific piece of work undertaken with the ward sister charge nurse to make sure that we provide the necessary training into the team as well. So hopefully that helps address the second question.
Thank you. Thank you.
Lisa?
OK, thank you. In terms of the first question, yes, the People Committee do have workforce metrics regularly, which includes training. And in the October meeting, we are having a deep dive into the Making a Difference training programme. So we'll be able to give numbers of people who have attended from which locality and which staff group. So we'll be able to focus our efforts on anything that comes out of that deep dive that we need to address.
Thanks. Thanks very much, Lisa.
Thank you, Lisa. Paul? Sorry, Miss Barbara.
Sorry, I thought you were going to go to Barbara.
I should have gone, excuse me. Shall I bring in Barbara? Okay. Sorry, Barbara.
No, please, it's fine. You go ahead. It's okay. Mine can wait.
Okay, we won't scuffle over that then.
No,
yes, in relation to triangulation, this is something else that I've been engaging in, what I might describe as mentionitis about over a number of years. Can you clarify, has a decision been made yet as to which metrics are going to be used as part of that triangulation exercise, and how does that fit with what you said a few minutes ago about how you were able to identify what you characterise as hotspots? It seems that those should probably be one and the same, shouldn't they?
Absolutely. So the work that a member of Hugh's team has been doing, Catherine Evans, to make sure that we've got the necessary dashboards and metrics and the quality, what against performance and everything else is actually being pulled together, and it's being pulled together and we are using it. And certainly staff at individual team level are beginning to use that data as well independently. So yes, you're quite right. If we're seeing a hot spot, we should be alert to that before it actually comes to a realization. So making sure that we're using our SPC charts, our metrics, the measures to help us have an early warning is really, really important. We're in our infancy, let's be honest. We've used data not to the maximum effect over the period of time, but that I think is coming to a place now where we're much more confident with the data that is available and how we actually create reports that help us triangulate in a much more automated way than some of the manual mechanisms that we've had to do up until now. I'm sorry, I'm not sure whether that answers the question, Paul.
Sort of, I guess. I think to be clear that you have got criteria, the metrics that you're going to be using for the purposes of producing these reports. We've got those in mind, and it's just a question of doing the engineering, as it were, to make sure that the reports use that data to give us the information we're asking for.
Absolutely, and already we are using the quality measures that we've identified that link in both to the Nurse Staffing Levels Wales Act, but also the Quality and Engagement Act, and we will be having a board seminar in October specifically around that. And in fact, in the internal implementation group meeting that I've got next week, we're going to be looking at the measures that we can not just utilise internally, but what can we actually start reporting to our public as well, particularly in the context of quality and safety. So it is all beginning to come alive, I suppose.
Thank you, Mandy. Barbara.
Thank you, Chair. Yeah, my comment really is again about the low numbers of paediatric responses, and we're very much an advocate of the walking the shoes of children and young people as of all patients. And what I should have said first of all is thank you very much for your comprehensive report, but that it is somewhat lacking in the paediatrics there. I recognise it's quite a short period of time. I also noted that there were a number of responses from Puffin Ward within that period of time, excuse me, which I understand well, which was closed at the time. So I wonder, where they slipped in. But really, the question is, what might you do to be able to increase those responses from paediatrics, children, young people, and their families, to get a better view of what it might be that they find good or not so good, etc.
I think that's thank you for that question, because it is such an important area, and it's one that if I'm honest, we are continuing to struggle with. Our numbers go up and down from month to month, and I'd have to say that's not for want of trying with the staff approaching both those that are in hospital. But the area of work I want to tap more into is how do we capture feedback from those that are in our community. So certainly from our continuing healthcare environment, looking at what we're doing with our complex community care packages, and how are we using the opportunities that through the children's plan that Andrew is leading, we can actually make sure that we're capturing that feedback more heartily. So it's not something that we're saying is good enough. There's always more that we can be doing, and we're always open to suggestions as well. So I would gratefully receive any ideas on that.
Barbara, thanks, Mandy. So thank you ever so much. Mandy, can you pass on the board's thanks to the team, to Louise and the whole team in drawing this together, and the work that's done to bring the voice of patients to the board directly. So thank you. And is board happy to accept the recommendation? Diolch yn fawr, thank you. So we go on now to 3.3, Making Malnutrition Matter Business Case Update. Alison.
Thank you, Chair. So in the interest of time, I won't pull out too much from the report, but I'm pleased to bring the closure report to board relating to the planning objective, which is now closed in relation to the Making Malnutrition Matter business case, which was approved for investment by the board in September 2019. The paper that you've got, you'll recall that the investment was to deal with some very real issues that we had at the time, and I'm pleased to report that the two extreme risks that were on the Health Board's risk register at the time have been closed with the expansion of the service. I think it's fair to say that nutritional status is only one thing that impacts on the health of an individual and their ability to recover from illness, and sometimes it's quite difficult to show that direct impact. But I think what the team has done in the report is called out, albeit in some small numbers in some cases, a variety of things where we can see a direct impact from interventions by the dietetic service in a specific area that is shown improved nutritional status in individuals, a reduction in IV fluids, a reduction in artificial nutritional support. There's clearly a lot more that still needs to be done, but I think for me it does demonstrate some impact across quite a wide wide areas within the system. We were also hoping to bring a patient story today, but unfortunately it isn't quite ready. So we will circulate that to board members in the up and coming weeks, just to provide a sort of patient and carer lens to this as well. But I'm going to hand over to Karen Thomas, who's our joint head of nutrition and dietetics, who may want to pull out some key points, but if not, we'll certainly answer any specific questions that anybody might have.
Many thanks, Alison. Welcome, Karen.
Thank you, Chair. Thank you, Alison. As Alison has articulated, this paper aims to set out the progress made with the Making Malnutrition business case to date, including, we believe, significantly improved dietetic response times, both to hospital and community referrals, and a snapshot of the associated measurable patient nutritional outcomes. It also describes the Nutrition Champions model, which was significantly delayed due to COVID, but continues to be actively implemented. And there is an illustration of the benefits, both from a patient perspective and an organisational value perspective, of taking that whole system approach. We fully recognise that releasing the full benefits of making malnutrition matters requires a community-focused approach, and I hope this paper illustrates some of the examples of the range of developments that we've initiated in order to make progress towards releasing that benefit, particularly in relation to identifying people's risk earlier and working more upstream. Work absolutely continues to deliver the full ambition and the benefits of this plan, and that also requires a very collaborative approach. I'm very happy to take questions. Thank you.
Karen, going to open for questions. Jill.
Thank you. Really welcomed the paper, Alison and Karen. And one of the things we were talking about earlier on in the board was the issue of discharge put to care homes, for example. At the recent care home event, and we did have an excellent presentation on the use of oral supplements from one of your team. But one of the things that I think is really important to promote is this sense of community dietetic champions or in our care homes, so that we can do our best to reduce the impact of loss of nutritional status resulting in frailty and admission to hospital. And I think this is an area that I would still like to see developed further, where we have that community capacity.
Thanks, Jill.
Thank you, Jill.
Please come back, Carol.
Yes, absolutely. And I think we can take the learning from the Nutrition Champion model, which we're currently focusing on our inpatient areas, and look at how we can transfer some of that over to our care home settings. I do feel that would be a benefit.
Thank you. Yeah, I think the board would totally agree with that, particularly following on the discussions that we've had about admittance and discharge. And any other questions? Could I ask a question about on page 8, it says that the dietetic assistant practitioner periodically attends A&E and CDU to help patients who've been in for over 24 hours, assisting with screening. What do we mean by periodically? So obviously that's not all the time.
No, we have limited capacity. We have one dietetic assistant practitioner on each of our acute sites, but we recognise that the front door areas, our A&Es, our clinical decisions units, are key opportunities to influence somebody's trajectory immediately for hydration, which is an eminently modifiable risk factor, particularly for older and frail patients, but also for other patient groups as well. It is periodic, so our ambition is to have somebody down there several times a week, but we realise that's limited. We are looking at ways, well, absolutely, there's active work going on around improving the whole system of nutrition and hydration in those areas, with the aim that we put in place a sustainable model that isn't reliant on one particular staff group, but where it makes that nutrition and hydration part of everybody's business, because we believe that's the way to achieve a sustained improvement.
Thanks, Karen. And again, we've been talking about, the care of patients in A&E previously on today's agenda, and I had seen that model in another large A&E, and not only was it to the benefit of patients and to the flow through the hospital, but it lifted morale of staff who were getting on with doing the medical stuff, you know. So yeah, I think we'd also support that. Dylan would like to come in, and also there is a message from Anna in the message bar, which she says that your work has been presented to the Quality and Safety Committee and how significant the work has been to quality and safety. And it's great to be able to see demonstrable progress over recent years. And she'd like to see an update at the Quality Committee to really understand the impact. I hope that's okay. That's great. Dylan.
Thank you, Chair. Just a question really and a clarification. Is this an adult-based model only, or are you working with children and young people as well, especially in our A&E units?
It is adult focused. However, we have been working with the children's wards with respect to the nutrition champion model, but it would take a slightly different shape in those areas. So it may be that nutrition champion would be more focused on broader health and well-being as opposed to malnutrition risk per se.
Thank you. Well, a massive well done from the board, particularly you've won the, I see on page 10, you've won the Health Board led the way in screening for malnutrition during UK Malnutrition Awareness Week, and were awarded the top screener in Wales by the British Association of Parental and Enteral Nutrition. So well done, but thanks for everything you're doing. Look forward to report back to Quality and Safety on the impact. And could you pass on our thanks to all the team, please? And is the board happy to accept the recommendation? Thank you. Diolch yn fawr. So we're now going to go on. Thank you. Interim paediatric review, and that's Phil.
Thank you, Chair. So this is a really important paper of significant public interest. In fact, we undertook some public communications to direct the publics to this paper and attachments. The paper reports back to board following the agreement at the May 26th board and approval of our approach for the detailed plan for undertaking a review of paediatric services and the options appraisal process. The SBAR sets out the temporary changes that have happened since 2014 and the rationale for them, and also gives a summary of the issues paper that is attached. We've been supported all the way through by expert advice from the Consultation Institute, and we've also closely connected with the Community Health Council throughout the process. The issues identification process has therefore been completed, and we've attached the paper, as I've said, but there's some other really important papers attached, including the activity information, which gives quite a lot of detail about the activity of paediatric services. Also a report from the Consultation Institute, where there's a detailed report and a summary report, and also publications from the CHC, our Community Health Council. One was a visit report in 2018, which predated COVID, of course, but also a report from July 2022, more recently around the patient voice that they've heard. So it's really important that those attachments are visible to us as board, because they contain some really important information, and also they're considered carefully as part of the next steps of the options development and appraisal process. We're looking at how we involve clinicians in that. There's a strong amount of clinical interest in that, although there's a sort of particular process that the Consultation Institute is asked to follow, which means that we have to select a certain number of clinicians in that, but we're looking at how we involve clinicians as much as possible within that. But happy to take any questions.
Thank you, Phil. If I could open it to questions. Julia?
Yeah, Phil, thank you. It's a really impressive report, and so much data, and it's good to see the process that has been gone through and is continuing. I guess the question relates to some assurances on timescales. I understand
why this is taking the time, but I guess I'm also picking up sort of comments that is this being stretched time to such an extent that it becomes a fait accompli at the end. I know that's not the intention, but I'm looking for assurance that when this comes to the board in November, there will be a clear recommendation for the future, or for a time scale. And I know everything's supported in the way it's been done, but I just think we need to be clear that we will have that definitive report in November. Bill?
Thank you for the question, and I think one thing I'd just like to start off with is to pay tribute to Lee Davis and his team for the work that they've done on this process. It's enormously complicated process with lots of steps, and quite rightly so, because it's really important that we engage with our public and staff and follow the proper process. And it's quite complicated just because of the number of changes that have happened, and involvement of people does take time. And I think even with this extended time frame, that does feel like a long time, except that even with that, there are some real pressures in undertaking an option appraisal process in a really open and transparent, involving and engaging way before the next board. There are some real pressures even on the timeline that we have, and it might be best, Chair, if I bring in Lee just to talk the board through that.
Thank you, Lee.
Thank you, Chair. Thanks, Phil. So yes, there's been a huge amount of work over the recent months, as you can see through the issues paper, and it was important to do that in a very comprehensive way, given the fact that we've had temporary changes in place now over the last 6 years, and a series of different changes. So that was what we'd set out to do in May, and we promised to bring back the issues paper to this board, which of course we've done now. The work on the options appraisal has already started. We've done a deliberative session, and there are others planned over the coming month or so. So we are at the moment on track to deliver that November deadline. What we should expect, though, is that, I guess what we need to anticipate is that the options appraisal process the next month or so could come out with one very clear preferred option, or it could come out with a 2 or 3 options which we might want to consider as a board, and then there may be some further choices for us as to how we want to test those further with the public beyond that. So I guess we need to be careful that November might not be definitive in terms of us making that final decision. It's obviously a big question for us, and we want to involve the public as fully as we can. And I can see Barbara wants to come in from a CSG perspective, and I think we're aligned on our thinking on that point. But certainly I can assure the board that there's a huge amount of work going into this, and we do expect to stick to the timeline of bringing back the options in the November board meeting.
I'm going to bring in Barbara and Donna.
Yes, thank you very much. Thank you both for that, and thank you also for the comprehensive papers as well. Thank you, Lee, for the time you've taken to have these discussions all the way through. I've got a few points, if you don't mind me making. Firstly, we welcome the Health Board's focus on bringing to an end this temporary service changes, and to have a clear focus of where we're going from here. There's a couple of things that I would like to add there, really. We, the CHC, believe it would be of greater value, really, if identify the needs of children, young people and families, if data could be distinguishable against the different counties, so that, for instance, the major changes are going to happen or are happening to the people of Pembrokeshire. So if we could distinguish what those issues are, it might have some value. I think it will have some value when we come to options appraisal. and of course within that options appraisal, something that we would hope to see would that you would have patients, young people, children, young people, families on there, and also have an age range across the range where possible, respecting and identifying social needs, and the hard to reach groups that we don't always go to, because obviously, you know, your regular attenders, etc., will come under groups of people that perhaps are not always heard. Yeah, I think Donna will come in now if there are any more, but it's really just, I'm glad to hear you say that your continuous engagement is going to happen through this options appraisal process to identify which options might be there, but also wherever possible, if we could have a selection of users, particularly parents within those. I know you've had some in the in your recent meeting last week, but very few. It's such a major part of the change process for paediatric services, that, you know, parents feel very strongly on this. There's a lot of information, as I've mentioned before to you, Lee, in the Royal College report that was 2015 that discusses transport measures. That is going to be a very key, or the transport issues are going to be a very key process for families. But thank you very much. Thank you.
Thanks, Barbara. If I could bring in Donna before Lee responds effectively. Donna.
Thank you, Chair. I'm just echoing basically what Barbara has said, in that there does need to be significant user involvement in the next stages. And remembering that although the Health Board has had contact with families, etc., that people in Pembrokeshire some areas are particularly disadvantaged. They don't have access to a car. They're not able to get necessarily to an event, and there's a need to go into the communities directly to where they meet and where they're already comfortable, so that they can have their voices heard there. But as we said, grateful that the temporary situation in Pembrokeshire is going to be resolved, and we're going to look at what really is an interim solution, because we've got a new hospital being built, but that interim solution is going to be for a period of 9 years, which is a lengthy period of time, and therefore it needs to be the right one for the people and the children of Pembrokeshire and all our counties as well. So thank you very much.
Thank you, Donna. Lee.
Yeah, happy to come in there, Chair. Thank you, and thank you to Barbara and Donna for their comments. As has been mentioned, we've been having some quite regular dialogue on this, and I think we're all on the same page. What we're really keen to see is as much user and parent and child involvement in the process as possible. We had a lot of comments through the survey, so over 600 comments. So we've got a strong sense of the views in across the public, and we did involve some members of the public in the deliberative session are referred to, and the smaller working group that Phil just referenced now, which is trying to do the initial working up of the options following that session. We were aiming to get a 50-50 split between staff members and service users, so we're still working on that. It hasn't quite worked out as the way we'd want it in that sense, but that's broadly what we're aiming to achieve, and then we'll test that more widely back with the bigger group that I initially started, I referred to. And as Donna says, we've had those conversations about how do we reach out to the public and go to the groups themselves rather than expecting them to come to us. So we're going to work through that as to what we can do over the next couple of months and beyond that, actually, because I think this is a process that we're going to need to continue. Thank you.
If I could build on what our colleagues in the CHC have raised, there's a history here, and it has caused repercussions to people's trust in the Health Board in Pembrokeshire. So I think communication about the engagement process and how many people that we have listened to within Pembrokeshire, including clinicians in Pembrokeshire and at Withybush. I think it's really important to show the public. So, you know, and as Barbara says about the voices of children, young people, parents, as you've just said, going into their communities, and this is the distinctive data between counties, I think would be really important for public confidence. Do we have any other questions? Okay, again, we expect that we will have the options for our November board. If for any reason that is not possible, again, communication is key about the reasons, so that we can hope to keep the confidence of the public and the clinicians. So the board happy to accept the recommendation. Okay, thank you. Lee, we're now on to the your paper implementing Healthier Mid and West Wales Land Appraisal Consultation Project Plan.
Yes, thank you, Chair. So board members will recall that at the extraordinary meeting on the 4th of August, we agreed to take 3 sites through to the next stage of the land selection process. And as part of that, we also agreed to a formal public consultation on the 3 sites. So we've developed a plan rapidly to progress that consultation and bring that to you today. So this is a plan for the consultation, if you like, which sets out broadly the scope of the consultation, what we're looking to be influenced on and seek public engagement and views in, and equally then the timelines and the associated resources with that for that. In the paper we also cover some of the costs associated with progressing the land selection more generally, which I'm hoping board will be able to support today. And I've got Libby joining the call, joining the board meeting today to take us through the project plan that she's developed for us. So if it's okay with you, Chair, I'll hand over to Libby to take us through that briefly.
Thanks, Lee. Welcome, Libby. Over to you.
Thank you, Chair. So I just wanted to take the board through some of those key issues in the project plan that Lee has mentioned, just to confirm that the project plan sets out the scope for the consultation, which is key for the next piece of work that we need to do around the detailed consultation planning. And it also oversees the management of the process all the way through from pre-consultation to post-consultation. So I firstly wanted to just take the board to page 8 of the project plan, which is page 16 of the papers, and that just sets out within that the scope for the consultation, which will enable the board to make a decision on the selection of the sites going forward. So we have to set out in the consultation project plan those matters that are open to influence by the public consultation and those that are excluded from the consultation and therefore already decided. So I just wanted to draw the board's attention to that in setting out that those matters included and therefore open to influence are around the suitability of each of the 3 remaining site options for the new hospital and the positive and negative impacts associated with each of those of the 3 sites for the new hospital. And then in terms of what's excluded from the consultation and therefore not open to influence, that's in relation to our existing health and care strategy and those matters that were decided as part of the 2018 public consultation around our new urgent and planned care hospital, the 2 repurposed sites, Withybush and Glanwilly, and then a network of community hubs supported by our enhanced community model. What I also wanted to just draw board's attention to is that at this stage, although we're not at a formal consultation stage on services, facilities and detailed clinical models, this consultation provides us with an opportunity to continue that conversation with the public as part of our continuous engagement framework. So that won't be a formal part of the consultation in terms of the scope, but we will have a process in terms of continuous engagement around how we undertake that. So then just wanted to take the board to the timeline, which is on page 20 of the board papers. And just to talk that through very quickly, in terms of the first phase of consultation, which is around options development, to confirm that that has now been completed, with the development of this project plan coming to the board today, and around the 3 shortlisted sites. We'll then go straight into the pre-consultation phase, where we need to develop the detailed consultation plan, all of the consultation documents, and undertake a robust stakeholder analysis to inform our methods and approach to engaging, particularly those voices seldom heard in our consultation. The consultation will launch on the 26th of January 23 and conclude on the 20th of April, and we'll have a review at both the midpoint and the closing review. And the post-consultation period then will run through to July 2023, and a final report will be presented to the board at the meeting in July 23. And then finally, I just wanted to draw the board's attention to the resource and requirements analysis that's been undertaken to deliver this consultation project plan, and that's on page 21 of the board papers. And this is based on an analysis of costs from 2018 consultation and recent engagements and analysis that have been undertaken in terms of comms and engagement activity, to a total cost of just over 295,000. So on that point, Chair, there are a number of recommendations within the paper for the board's approval today.
Thank you, Libby. I'm going to open up for questions, but the important comment Hugh has made in the message bar, so I'm going to bring him in.
David, thanks, Libby. Yeah, but I guess my point is one of choice, and clearly recognise the long-term imperative to develop this and move our strategy forward, but also recognise that this is a cost of 642,000, that were we not to incur this, our deficit would reduce consequently. And at this stage, given our challenges, which I'll come on to in our finance report, that is an important point for the board to consider about the short-term imperative for financial discipline with the long-term imperative to move our strategy forward. So, Chair, it's a point I'd like the board to specifically consider.
Thank you very much, Hugh. I think Phil is asking to come in, could be on the same point.
Yes, yeah, it's related to it. My point, Chair, was that it's really great to see the work here, the detail of it, and the clear timelines. I think what I was going to say is that when we took the strategy to board in 2018, we recognised publicly that we had an unsustainable system, and the concerns, I think, of clinicians and many of the public every day is that this is a long timeline before we have a new hospital in place and a new system that would solve many of the problems that we see in our system at the moment. And I think the concerns, the urgency, I think, from clinicians out there would be that we press ahead without delay, and actually the timelines as they are seem too far away. And not only that, my other concern would be that if we were to I suppose slow down or change the timeline, then the risk of loss of momentum would really concern me as well. And it would be really difficult to get up to the sort of pace and momentum that we have at the moment. So I just wanted to make that point, accepting the risk that the finance director has put to the board and the concerns that give us.
Thank you, Phil.
Yeah, I'll just come in if I might. I think Director of Finance is absolutely right to put that into our consciousness, because these are the decisions that the board is best placed and needs to make about short-term imperatives versus the longer-term need. You know, I've got a personal view about, as Phil's said, around the absolute urgency to be getting on with this alongside everything else we're doing, but it is to recognise we find ourselves in a really difficult position given our financial position. But I personally would support that we need to continue this piece of work.
Thank you. Winston, did you want to come in?
Yes, I do. I think it's right for the Plans Director to highlight the costs at this stage. I just want to confirm the costs in this paper, are they expected to be incurred in this financial year, or are we saying a commitment over 1 or 2 or 3 years?
These are mostly in this year, but some of the consultation costs that Libby picked up could go into next year, depending on how we want to manage that, I guess, to some extent across that 6-month period.
But thank you, Lee. I'll leave it to you guys, execs, to sort that out in relation to our financial position forecast for this year and the Welsh Government's view.
Thank you. Thank you, Libby, and thanks for all the detailed work that has gone on and for the papers that have come to us today. I just want to test with the board. As you know, the strategy was agreed at the end of 2018. We were hit by COVID. We've really, through Lee and the team, we've managed to really progress in the delivery of the strategy to date. The reason that we have this strategy is our system that we have currently is unsustainable in terms of provision of services and serving the public, and in the terms of recruiting and retaining staff that we need to deliver those services. So yes, there is, and quite rightly, Hugh, you brought that to our attention. We could look at through the short term and call a halt, but we know the only way to deliver financial balance is by delivering this strategy. So is the board happy that we continue with the consultation plan? Yeah, okay, thank you. And
sorry, there's one point in governance that on the consultancy, which is detailed in the paper, we absolutely need to follow our standing orders and advise on how we procure any consultants, because that's going to be really key.
Absolutely. Can we include that in our decision, so absolutely, it's clear for record that we follow in relation to any consultancies our standing orders and all the regulations that we should and will follow. So with that included, is the board happy to accept the recommendation in the SFAR? Yeah. And as you said, the procurement of consultancy is a process and governance issue which will need to come back to board.
Yes, Hugh and I can work with Lee on that because we've already had some preliminary discussions, Chair.
Okay, many thanks. Thank you so much for all this. And you know, it also, at a time of such pressure, it gives us hope. There is a light at the end of this, and this is a big part of that light. So Diolch yn fawr both, thank you. I'm going to have a short break, please. We'll come back at 12:05, if we may. We aren't behind, but every item's important that we've discussed. I'm sorry, I think we're going to have to be patient today, but we'll try and motor on when we come back, because a lot of the things we've discussed so far are in later papers anyway. So thank you. Okay, 12:05. Right, so welcome back everybody. We're going to go straight, and we are running late, so many apologies. Again, if we could try and be concise. The next item is financial report. Hugh.
Sorry, we were navigating technology there. Hope you can hear me.
We can.
Great, thank you. Thank you. In terms of the finance report, it's a format that board members will be very familiar with. It is a format I want to revise by the time we next meet, and the reason for that is having gone through the process now of recognising a deficit as it is, with the contribution that our COVID legacy costs and our operational pressures are making within that deficit. Now's the time to really shift the report to focus on the drivers to that deficit, which, as we alluded to earlier in the annual plan paper, covered between 42 and 47 million of our deficit position as a modelling figure. So a large element of it is being addressed, or at least embraced within that annual plan response. I do want to just go back over the transition from COVID to core that the process that we've followed over the last 3 months, and we've been through a number of iterations now of recognising what is going to be a cost pressure for us within our core position. We recognised before about 17 million of savings that weren't going to deliver this year. That number has come down slightly this month to 16 million, and the reason for that is that we have been able to use the WellSky system, a new pharmacy system within our hospitals, to charge more appropriately the cost of our in-hospital medicines to our commissioning organisations, so mainly Betsy, Cadwalader Health Board and Powys Health Board. So that's improved our savings performance slightly, but that's been offset, so our position hasn't changed overall, by our medicines management and our primary care prescribing growth that I alluded to earlier, with the cost per item increasing, and also for us the number of items being dispensed having increased. As I say, the date is about 2 months out of date, so that does give us a risk that I'm monitoring going forward. So that's the savings and operational pressure shift, and then the shift from COVID to core has largely remained as it was, as I alluded to in our last meeting as a board, and nothing significantly has shifted there for us. Now, if I turn to the second page of the report, I am conscious that in having a sea of green there with our forecast position, that is a misleading picture, because of course the risk in our position is a very significant one. What I'm alluding to there is that the risk of further deterioration against the savings position, the revenue position, is low, but of course the position itself is not acceptable. And in particular, that is coming out as a significant concern in cash management. And for me and my team now, over the next month or so, very much focused on what our cash management mitigating actions will be, which I'll bring back to the board in November for the board's consideration, or our next meeting, SRC in November. So we'll bring further work back on that. Just for assurance though on our process, and I'll conclude with this because I think we've probably talked about the numbers and the drivers to a certain extent in the annual plan discussion. Just for assurance, we do have use of resources meetings that are happening now with each of our escalated directorates on a monthly basis, and we're doing the first round of our quarterly use of resources meetings with those directorates that aren't overspending but are operating within their means, just to understand whether there are further opportunities within those directorates. We also have a weekly use of resources meeting for our executive team that's providing assurance to the executive team on our financial position and on our use of resources more broadly. And we have a weekly PAC which includes our performance position and our finance position, that is going back to our executive team each week to keep an eye on those areas that are particularly risky and those opportunities for change. So, Chair, I am conscious my biggest worry at this point in time is our cash position, and we will bring something back at our next meeting to go through that in more detail.
To you, and thanks for the papers. They're really, really clear, and I really like the new format as well. In relation to cash, how confident are you? Because again, like you, that's my greatest concern. How confident are you that we will have sufficient cash next the end of the financial year?
At this stage, I'm not confident that we would be able to fund our payments in the last couple of weeks of the year, and that's the issue that I need to address now through conversations with government in terms of what that could mean for us, but also our own mitigating actions that we could take internally. So we will be working on that, Chair, to provide that assurance. That's the area that I'm particularly focused on.
Okay, thanks, Hugh. The other question I have, at the last board, we basically put ourselves into targeted intervention, and I just wondered how those things that I know we're meeting weekly as IMs with the chief executive, have those other things been put in place now? I know it's external agencies as well.
Yeah, so the letter went in to Welsh Government following our board meeting, making some requests of them. We're still waiting for a formal reply on the consequences of that in terms of an escalation status change. However, all the various discussions are going on in the background. So I think it was in Lee's annual update paper that showed our response to each of the issues in the interim letter we had back on the 15th of September from the Director General. I think we're just waiting now for their confirmation of how they want to interact with the executive team as a total team in Welsh Government. At the moment, we're still doing it through the various IQPD meetings and so on. So there's still a bit of clarity to come, I guess, in some ways.
That's great, because I know we did say about asking the delivery unit to come in once a month, etc., etc. So there's still clarification.
Yeah, for the FTU and the DVU, we're just awaiting final response.
Okay, that's grand. Thanks, Winston.
Yeah, thank you, Chair. Quick question. So Hugh, you and your team have been very consistent in reporting the financial position and the underlying drivers to that: demand, inflation, energy, and other pressures. I just wondered what extent to which you're being supported by the Welsh Shared Services in terms of tackling the inflationary pressures of fuel and others. Do you feel you're getting the right level of support at the moment?
Yeah, thank you. I can pick up one of those areas in particular as a case in point. Energy is an area that is being procured nationally across Wales, and there's an energy price management group that is hosted within Shared Services that probably hasn't had a huge amount of focus or scrutiny in the past, but that scrutiny has certainly shifted recently. And they provide a very sophisticated response to the procurement of energy on the forward markets and on spot markets, as and when the shift in prices impacts. But clearly that's not been enough this year to offset and mitigate the impact that we've had. As I said, the UK government's announcement for support to business and the public sector does give us some coverage between now and the end of March, but unlike for the domestic supply coverage, the business and public sector one only covers us until the end of March. So that gives us a very real concern going into the next financial year and how we might respond to it at that stage. But the support from Shared Services is commendable in energy in particular. And more broadly, in terms of our support from procurement, clearly we're not seeing a year where we're delivering any procurement savings, but the work that the team are doing is very much focused on mitigating cost pressures that are coming through. With all of these inflationary pressures, yes, they are going to have an impact on our ability to deliver against the 62 million. Actually, the biggest element of delivery of risk remains flow through the system. So regardless of all of these inflationary pressures, actually flow of patients through the system is the biggest single issue that is driving our base and the impact that on agency.
Thank you. Thanks very much.
And if I could bring in the Chief Executive as well, please.
Just to build on that point, that's why I think it's important to bring that cost back to board at the next meeting in the newly signed report.
Yeah, thank you. Are there any other questions? Now we've gone into a lot of detail about our finance under the annual plan item. Okay, thank you. So the board accepts the recommendation to note and discuss the financial position. Thank you. Integrated Performance Assurance Report, Hugh.
Chair, thank you. My able assistant here is managing the technology very well. So thank you, Mandy. The integrated performance report is presented again, similar format to how this has been presented before. I'll just cover off pages 4, 5, 6 and 7 in terms of the key initiatives that have been taken throughout this year, particularly virtual appointments, which has increased further. Work that's been done around increasing our capacity, recognising some of the challenges that have been in planned care recovery because of areas of support staff shortage, like in health records. So the capacity has now been increased. And capacity increases around mental health assessments and physiotherapy staff. Also looking to insource within endoscopy to provide additional support within diagnostics. So some very important measures within increasing our capacity. Quicker diagnosis, another area of real focus as well, particularly 2 areas, the fecal immunochemical testing within primary care to get the rapid diagnostics in place and reduce the demand on endoscopy services. So a double whammy impact of that measure, and rapid diagnostic clinics for suspected cancer patients. And so there have been some real initiatives to drive improvements. Within on page 5, then, recognising the challenges within urgent emergency care, but SDEC and the same day urgent care service within Cardigan, again having an impact on that system, but recognising that it's not showing itself necessarily within the performance information we're seeing for urgent emergency care, which I'll come on to. Ambulance triage, clearly another important element given the pressure on the ambulance service, and early releasing ambulance crews where there are emergency calls. These are important mitigating impacts, but recognising they're not in and of themselves shifting the dials. There are a number of key risks that we're seeing within our performance. Clearly, we've talked about vacancy gaps and staff shortages generally, which is now running at about 10%, which in and of itself then is having an impact on our agency pressures, demands across our services, and in particular patient flow, where at the middle of September we were looking at 283 medical optimised patients and 134 patients who are ready to leave our services. Clearly that has a big knock-on impact that we've talked about before in today's meeting. And the other one just to highlight on page 7 is patient acuity, where we have seen that very steady and gradual increase in patient acuity, especially in terms of level 4 and level 5 patients, which is again driving a demand for our nursing workforce. And I won't go through the rest of the report, Chair, recognising that there are a number of measures which have declined in particular. Of course, there are people at the end of each of these measures, and the impact on outcomes and patient experience is something that, as an executive team, we are very focused on and aware of. So I don't want numbers to dismiss the impact that this has on people's everyday lives. Welcome questions, Chair.
Many thanks, Hugh. Open to questions, board.
Yes.
Judy.
Yeah. It's maybe
not such a question on the figures, but it occurred to me reading the development at Cardigan, and I saw in my own eyes the increased number of people who are attending there. I'm conscious we've not really done a review of the impact of Cardigan and looking at it as a model. We did work initially when it was opened. We promoted it as part of the new service, but I just wanted not to create more work now, but at some point thinking about the facilities in other areas of other counties, something about a review of Cardigan and to an extent Aberystwyth, although I know that that's slightly different, just to be able to give people some examples of what has been achieved by having those services, because certainly I've noticed in Cardigan it's increasingly utilised every time I visit, and I just wonder if at some point we could look at that.
Chair, yeah, absolutely. I guess, you know, we're at a stage now where we do have enough data to be able to make some assessments, and I'll pick that up with outcomes and experience in mind, as well as the impact that it would have had on performance. I'll pick that up with the team, Chair, and bring that back through one of the subcommittees.
Yeah, thank you.
Lee, did you want to come in on that?
Yeah, thank you, Chair. Yeah, I was just going to add, so we have done a review of Cardigan as from a capital planning point of view, as in terms of delivery of that as a project, and some learning from that, not just on the delivery of the project, but obviously in the bringing the teams together into the new setting and the implications of that, and to what extent we've achieved the objectives we set out to achieve with the service model and service delivery. So some of that has been done. I think Judith's point is an important one, though, because probably Hugh, myself and Andrew and Jill, a combined effort, I think, to really test the implications of that model on the wider system, the impact on the wider system, and what that might tell us about the direction of travel we're heading in from a strategy point of view, and what opportunities that could give us in the longer term.
Yeah, thank you.
Sorry, Steve.
Yeah, just to come in on that, thanks. I think that'd be really good, really timely, I think, to do that, given the model is now embedded and starting to flourish, both in Cardigan and I think in Aberystwyth. So I wonder, it sort of links to me in my head with some of the discussions we've had with public and local elected representatives about the public understanding of the opportunities that integrated care centres provide. So bearing in mind that we do expect solutions to look different in the different areas, there may be a piece for Olwenna here to think about how we might capture some of this in materials that we can then share with Llandovery, with Tenby, with Fishguard, about actually what's been achieved in those areas and what that's meant for patients and indeed the services that are available. So I think if we can wrap some comms around it as well, give some thoughts to that might give us a really good tool moving forward.
Thank you. And you know, when we have been out through the summer to listen to people, they tend to focus initially on the new hospital, when the actual foundation of the whole strategy is these integrated care and health centres throughout Hywel Dda. And we have taken some people from different areas to visit, and we'll Aberystwyth and Cardigan, and we'll continue to do so, because it's hard to visualise in the abstract. But when you meet the staff and meet the patients, they are really, you know, the experience seems very, very positive. That's great, thank you. Dylan.
Thank you. My question really is about on page 10 about our infection rates, especially in C. diff and Klebsiella. Is this a national trend that we're seeing for health boards, thinking about the reduction in hand washing and infection control for members of our community, or is it something that we should be concerned about as a health board in particular?
If I can come in and respond to that point, please. Particularly in relation to C. diff, it is something that C. difficile, which is being seen on a national basis, national UK-wide basis, in terms of an increase. In terms of what we're doing specifically, you will be aware that we had World Patient Safety Day recently, And as a consequence, unfortunately, of Her Majesty's death, we had to delay some of the messaging around that. But nevertheless, because it was focused around medicines and safety, etc., we took the opportunity to start a piece of work specifically around antibiotic prescribing. I've also met with a number of clinical leads across both the secondary and primary care services to look at what more we can do, particularly in the context of Start Smart and Focus, a particular approach that we've adopted. And we have also submitted a fairly detailed plan into the delivery unit about the actions that we'll be taking, not just about antimicrobial prescribing, but actually some of the getting back to basics work as well, including as Delith has mentioned, focus around hand hygiene, cleaning standards, to make sure that we are tackling C. diff and indeed all other infections head on. I have the fortune of chairing the HCAI Healthcare Associated Infection Delivery Board on an all Wales basis. And in fact, at the most recent meeting, we actually had a presentation from Michael Perry, who works within Cardiff University, proposing a piece of work that would be taken forward as well. And certainly as a board, we were very keen to support that. And it's something that we're certainly going to be getting behind as well.
Thanks, Mandy. And I think Phil wishes to come in about Cardigan and ESDEC, which is the same day emergency care.
Yeah, so ESDEC, same day emergency care, really important initiative, rerouting people from the A&E, away from the A&E department to get rapid assessment by a specialist. We have this in operation not only on our 4 acute hospital sites, but also in Cardigan. So the chief medical officer visited the ESDEC in Cardigan, and was really impressed, I think, by ESDEC there, because it provides a really important service to people of that surrounding area who, given the geography, would have to travel a long way to go to one of our front doors. The issue is that I wanted to raise is that whilst this is excellent, we have 5 ESDEC facilities in our system, and that is because of our structure. And our geography. If we were in a different system where we only have 1 or 2 hospitals, as many of the other health boards situation, we could centralise our ESDEC much more easily, and therefore it'd be much easier to resource. So there's a workforce and a cost implication to having 5 ESDECs as opposed to say 1 or 2. And I suppose it just is another example of just how hard it is to staff and finance our system as it is at the moment. But we're doing this because actually it provides really good patient experience because people don't have to travel so far.
Thank you, Phil. Are there any other questions? Do you want to come in on this or on the operational update, Andrew? You choose.
I don't mind whichever suits. I wasn't sure it was easy to do it now as we're talking about performance or whether to wait.
Yeah, come in now. Thanks.
Okay, I just thought given that we were picking up performance and where we are, it might help just to link the 2 conversations together. So I think the areas we talked about urgent emergency care earlier in quite some detail and the pressures and challenges we're seeing. And as Hugh highlighted and presented in the report, I'm very conscious that with all of these measures and targets, there are individuals and people behind them and experience. And we know as we've reflected this morning, we know in a number of areas we would want to be doing an awful lot better in terms of the experience and service we're able to offer, even within the context that we're operating at the moment. So I wasn't going to say too much about urgent emergency care because we talked about. I just wanted to highlight a couple of others. We'll remember that last board we brought a detailed paper on the mental health access and waiting times position to update on our proposed trajectories. I'm pleased to see that 2 months on and at this board we are seeing the improvement that we in line with what we set out a couple of months ago. So that's encouraging in terms of the actions that have been taken and the plans that we've got to improve access in that really important and key service area for us. I also wanted to highlight that it's probably worth reflecting that in terms of cancer delivery, Welsh Government through our integrated performance and quality delivery meeting are taking a slightly different approach to monitoring our progress on cancer at the moment. So they recognise that in order for the system across Wales to deliver a sustainable level of cancer, single cancer pathway performance, we first need to be able to clear the backlogs of patients or delays in the system of patients waiting in the pathway for diagnostics and treatment. And in clearing that backlog and reducing that backlog, you will inevitably create a position where your single cancer pathway performance metric is worse because of the way that the performance is calculated. So they're very much tracking us on our backlog reduction rather than our performance figure. And in terms of our backlog reduction, we are, after a blip in July, which was caused by a backlog in some radiology reporting that we've addressed, we're now back on track with that backlog reduction, and the figures for September are still being validated, but we look, and I'm confident that we'll be at where we said we would be for our backlog in September as well, which is a further reduction. So that is heading in the right direction. We anticipate by the end of this year, going into January, we will start to be able to get our single cancer pathway performance then up to above 70% and close to the 75% single cancer pathway target, as the backlog will be at a level that will enable us to manage that and do that. But the final point I just wanted to make here as well was in terms of planned care, which has obviously got a very high focus nationally with Welsh Government and with the Minister. Within our plan in June, we obviously set a plan and a series of trajectories that didn't get us to zero against the 52 weeks for outpatients or zero for 104 weeks for inpatients. But in terms of the trajectories we did set, we have been undertaking a deep dive stock take of where we are with our plans over the last 3 or 4 days. And I have a growing confidence that we will be on track to hit what we said we would hit when we provided our trajectories to Welsh Government in June. So that's that feels like a increasing confidence and not complacency, because there's a number of factors that could come in, not least the urgent emergency care challenge that we talked about earlier on. But there is a sense from the team that the plans we've got will deliver what we said we would deliver, and there are potentially some opportunities in there, but I'm cautious about those because of some of the other contexts we're operating in at the moment.
Thank you, Andrew. Really assuring. You know, it's the board's priorities and the minister's priorities. You've just gone through cancer and planned care, and I was at a meeting with all the chairs and the minister last week, and in many of the performance measures we were doing really well. Obviously, massive room for improvement, but we don't underestimate what everyone's doing to get us where we are. Thank you very much. And during all our public meetings through the summer, the biggest message was the here and now. You know, it's important that we're delivering the strategy, but our performance here and now. And I know you're doing everything you can, all the teams. So thank you. The board, I also wanted to add, for the public in particular, the performance report has been reviewed in detail by one of our committees, by 2 of our committees actually, and a lot of the questions have been asked in those committees. So thanks everybody. Board happy to accept the recommendation. Thank you. We now go on to the corporate risk register. That's you, Steve.
Yeah, I'll be relatively brief, and the board secretary might want to reflect on this as well, but just to say to the board, the executive team now reviews the board assurance framework, which is made up of both the measures to measure our progress against the strategic objectives and the principal risks that are attached to those on a regular basis now. And the executive risk group also reviews the corporate risks that sit above our individual directorate level, but are things for us to manage. So this is a setting out the current position in relation to the corporate risk register, kept under regular review, and the board is asked today to note those and and be assured that we've got the right risk scores in there. I've seen many of the things we've reflected in here, we've talked about today. So it does feel like there's good resonance. Joe, I don't know if there's anything specific that you wanted to raise.
The only point to raise, Chair, is really that the risks have all been through the committee structure. And as the Chair of Quality and Safety has previously said, risk 1027, which was a real area of concern and still is a real area of concern from our Quality and Safety Committee, did have a deep dive, so if there are any other areas of concern, we do deep dive into them. The paper details a number of risks for you in the areas that are new. You can see that it's lively because we've had a number of new risks, 6 since we presented this the last time in board, and we've also had some risk de-escalating as well. So it's for any questions really for the individual execs who are the risk owners, if there are any, recognising we have done the detail in the committee's chair.
Thanks, Joe. It's really assuring to have the narrative before we get here that all the things that we are talking about are in there, and the fact it's alive. Any questions? Okay, thank you. Happy to accept the recommendation. Many thanks. Sorry.
Paul,
Oh, sorry, Paul, come in on risk 129.
No, yeah, no worries. Sorry, not quite quick enough on the fingers. Risk 129, it highlights there that we are effectively sort of competing against ourselves. And to what extent are we sort of considering the impact, which when we introduce one initiative, that's going to impact upon our ability to do something else, because it says effectively that SDEC and 111 and out of hours are all fishing in the same pool.
Yeah, Andrew might want to reflect a little on that, but I think it is thus at the moment, given our workforce challenges, that we have to manage that quite carefully. And I know Lisa was briefing me yesterday on some challenges we have in some areas that want to recruit, but the danger of that taking from others. And what we try to do is overall take a risk balanced approach to those sorts of when we're trying to bring new staff in for new areas. I'd have to say the things you've mentioned, Paul, are probably amongst our highest priorities, but the board, I think, should always keep in its mind that does run the risk of destabilising other parts of the system, given that we don't have a big market to draw from. But Andrew, I don't know if there's anything you want to add in relation to those specific areas.
Yeah, I'll come in quickly on risk 129, so I know my name's against it, but I'm also very conscious in answering the question that there's a planning objective that's with Jill around urgent primary care. So Jill may also want to correct me if I get any of this wrong or come in. But in terms of, I think it's a really good observation, Paul. And I think it's a challenge we've got. And I think in terms of the out of hours peer review that we went through about a couple of months ago, and we've just received the final report on, it does highlight, and as our planning objective did locally, but also the national view, is that we should be looking far more at a single urgent primary care service 24/7 rather than different out of hours 111 SDEC. We need to find a way of bringing those together under one kind of service heading, so that we don't have that competition developing and we're recruiting people into a service that delivers a range of different functions. So that is very much on our radar in terms of trying to address that. As I say, I don't know whether Jill wants to add anything, but I think that in short, that's where I think that.
I think you've described it very well there, Andrew, and I think it gives us the opportunity actually of offering different opportunities for individuals to work across that system with a sort of more portfolio approach as well, which can be sometimes more attractive, to be honest, than just filling out of hours slots.
Yeah, thank you. Thank you, Paul and Andrew and Jill. Any other questions? Okay, thank you. The board accept the recommendation, and we will now move on to the operational update and progress reports, much of which we think we've covered in other papers as well. But over to you, Andrew.
Yeah, so there was only a couple of things, as you say, Chair. We've been through a number of the topics through the course of the conversation board today, so I wasn't going to go through too much. There were a couple of points that I just thought it was worth flagging that we haven't necessarily touched on. But firstly, there's obviously a couple of references in the paper, one to the winter plan and one to the critical care staffing position, which we've got further papers to come on the agenda today. So it's just a flag that it's noting and bookmarking towards those, signposting towards those. The two things in relation to the operational update I thought I really wanted just to share that we haven't covered. One is just to reflect that obviously in the paper it describes an improved COVID position from the previous board paper. we've seen a little, at the time of writing, there were 35 COVID patients in hospital. We've seen an increase in that over the last couple of weeks due to a small outbreak in Bwrdd Hospital, which we're managing. But I suppose it's also important that we note that there is commentary nationally around potentially the autumn wave of COVID this year starting. So we'll have to monitor closely what impact that starts to have on services over the coming weeks and months. And then the other point I just wanted to flag, since the last board meeting, we have been managing across NHS Wales, but as a health board, as part of that, a national incident with regards to the Adastra IT software system that supports out of hours and 111 services. So that's a system that helps share information between WAST and the 111 service and our own out of hours team when they're receiving calls to 111 and redirecting them into our GP out of hours service. We've had to have a workaround in place for, it was originally thought this was going to be a very short period of disruption. It's turned into a much more significant fix requirement by the team on a UK level. This isn't just Wales, this is the whole of the UK that's been impacted. We are anticipating that by mid-October that solution will be in place within Wales. There are various tests and pilots of the rebuilt system going on at the moment across England, Scotland and in parts of Wales, and they all seem to be pointing towards, for us, we'll be back online with that by the middle of October. It has meant significant work around manually for our clinical staff in out of hours and for an additional admin requirement to help manage the manual nature with which that data now has to move between 111 into out of hours and then back into daytime primary care, for want of a better phrase for that. So I just wanted to flag that because that's something that we've been managing since the previous time, the last time we met as a board.
Many thanks, Andrew. Any questions? The updates, we've discussed most of it beforehand.
Just one point on, I know there's a wider paper later on sort of flu vaccination, but just to update on the figures here, which is really positive. To date, in terms of COVID vaccination, we've delivered a system just over 23,000 since the beginning of September, and that continues to be in that integrated approach across primary care and our MBCs and also community pharmacies as well.
It's great to hear. Thank you, Steve.
Just one other thing to highlight, though, it's the situation is, as we previously reported, around the command intensive care unit position, Andrew. Just to reflect that Andrew did raise it at the national critical care meeting that I chair earlier in the week. And actually, I think what's coming out of that is some learning from our system, which we'll be able to reflect back into the national work around the specification. I think it's fair to say the number of transfers that we've had to do has been significantly lower than we anticipated. So we're trying to capture the reasons for that.
Many thanks. Thanks, Andrew, and thanks to everybody who is delivering our services. We've accepted the recommendation that we now go on to the winter planning, and it's you again, Andrew.
Apologies, I'll be brief, Chair. So we were notified around 6 or 7 weeks ago, probably, maybe it's 8 weeks ago, informally by Welsh Government that there was an expectation we took a winter plan through our board and submitted a plan nationally before the end of September, and that was and at that point some draft guidance was shared with us, and the plan which is presented to board today and shared with board today is based around that draft guidance that was originally provided to us. In short, the approach is very different this year from Welsh Government. I think there's a recognition more and more that the seasonal angle of urgent emergency care is not really seasonal anymore, and that there's a consistent pressure and response requirement needed across the system. So they're very clear in what they have issued that this will be the last year of a separate winter plan, if you like, and in future it will just be an urgent emergency care plan that deals with pressures and escalation in demand through the course of the year. In that sense, their approach to the plan this year was really to say the basis of your winter plan is your response to the 6 goals of urgent emergency care document and guidelines policy document nationally, which I know we've been through in great detail in other forums with the board. So this winter plan really builds on that, reinforces that. There are some additional things we're doing just almost as an operational check going into winter. So we're going to review our escalation plans to make sure they reflect some of the levels of pressure and action that we may need to take given where we are from a baseline perspective at the moment with pressure in the system. And obviously some of the further actions we're taking, and we talked about already today around home-based care, will feature heavily in terms of how we mitigate some of the pressure, the alternative care units, and how we deploy staff. All of those things are obviously a key part of this plan. But for us, just very briefly, our plan really is, as we've said, to reduce conveyance, reduce conversions, that's the number of people being admitted, and to reduce complexity, which is to kind of improve discharge and get people out quicker with a lower level of need. So I wasn't, there are sections in here, and we've got a paper, I know there's a paper later on around the vaccination programme, so there's a section here that picks up the respiratory vaccination programme. The final point I just wanted to make is we did then last week receive a formal set of guidance from Welsh Government on the content of the winter plan, and whilst it by and large is the same as what we've worked to in preparing the paper for board and the plan, they did provide with that some modelling assumptions around the potential impact of various respiratory viruses, so flu, COVID, RSV, over the course of the winter. So we're just working through those from informatics and from an operational perspective to understand what that might mean in the context of our plan for this winter. And we'll obviously review and come back if there's any significant changes we need to make. But I don't think there's anything else I wanted to say, Chair.
Thanks, Sandra. Very comprehensive. We also had an excellent presentation at the annual medical conference yesterday on the 3 Cs from Rhian, and there was buy-in across all specialties and primary care, but that's where the focus is, you know, should be. Thank you. Are there any questions, or the board happy to take assurance and approve the winter plan? Yeah, okay, many thanks. Thanks, Andrew. So we now go on to the critical care staffing position. Andrew again, yeah.
So it's still me, sorry. I think you get a break from me after this one. This is an important paper as well, really. So this, you colleagues will remember that, or will be aware that in August we had to take a very urgent operational decision around the critical care pathway in Carmarthenshire, based on the position with, in particular, the consultant, or the medical recruitment position, the consultant on-call cover position. At that stage, we were identifying that through August and September, there were a significant number of rota gaps we were going to need to cover, that we weren't getting a good supply of shift cover through for either through locums or through people being able to work additional, because the number of available consultants internally had reduced to a level that meant there just wasn't, they were already working as much as they could, really, in essence. We therefore changed the model in Carmarthenshire. We discussed that at the time with the Community Health Council, and we discussed that through the Quality and Safety Committee too, which saw patients for escalation, or that may require escalation to level 3 care, so that's intubation, being transferred from Prince Philip to Glangwili Hospital and the critical care unit there. We've continued to maintain level 1 and level 2 care on site, and the ability to stabilise patients ahead of transfer. And the aim has always been to make sure that we plan those transfers so that they're done during daytime hours, when it's easier for some of the national support services like the All Wales Critical Care Transfer Service and EMERTS, for example, to support the safe transfer of those patients. We had anticipated at the time that we made that change that we would see 2 to 3 patients per week potentially requiring transfer, and as Steve highlighted a few moments ago, we've actually seen a much lower level than that. At the time of writing the paper, there had only been 6 transfers, 2 of which were because the individual needed and required tertiary critical care provision at Morriston Hospital. Just to update on the numbers, just to give a sense, since the 4th of September, we've had 2 further transfers from Prince Philip to Glangwili, so still well under the and within the level of transfer activity we perhaps were anticipating. Having been through this 10-week period trying to recruit, we've not really been able to, we haven't been able to recruit additional consultant cover or locums to enable us to get to a place where we could safely reinstate the service and the pathway as it was before, so to not have to transfer that cohort of patients to Glangwili. The impact of not having to provide cover for 2 sites, which has been a deterrent for recruitment and certainly has been a deterrent for people coming to cover shifts. It certainly helped in this interim period, not having to, not expecting people to come in and cover the 2 sites and the beds in both sites. But we're therefore not really in a position to reinstate the service with the level of medical cover we've got. The difference between reverting and staying as we are currently and have been over the last 10 weeks is effectively we halve the number of vacant on-call shifts that we need to cover, which feels a much more safe and manageable level to be at going into winter. We did debate as a service whether we would want to suggest we put in place this arrangement for the whole of the winter, so for the next 5 to 6 months, but there was a very keen view that we didn't want that to signal we were stopping on the recruitment effort. So what we're proposing through this paper is that we obviously continue to try to recruit, but if we can recruit, we will look to reinstate the service in Prince Philip, and as a kind of milestone, we'll look to bring an update back to the board in January that just confirms where we're at with that process. I think everything else is in the paper anyway, so I will pause it. But in essence, the recommendation here, or the ask here, is that we extend the current arrangement and pathway we've got in place from the 3rd of October, when it's due to end on Monday, to until January, when we'll review the position again.
Thanks, Andrew. A question based on my visiting some of the sites is the ambition in our strategy is to bring together Withybush and Glangwili to an urgent and planned care hospital. And I'm picking up, because I'm based in Withybush quite a bit now, that there has been either one or no critical care patients in that unit, and there are staff. I'm just wondering why we haven't included the critical care availability in Withybush in this.
Yeah, so that's a really good point to bring up, Maria. So in terms of the transfer of critical care patients, from a critical care network perspective, the policy would be that, and therefore the operating practice and SOP is that you would transfer to the nearest available critical care bed to where you were transferring from. Now, obviously, for Prince Philip, that first port of call would be Glangwili. Actually, the second could well be Morriston if they had a bed available, and then you would be looking towards Withybush as part of that solution. So I know that question has been picked up with Mark Henwood, the Assistant Medical Director for Acute Services, is picking that up and having a conversation with the clinical teams around how that works. But in essence, the kind of clinical best practice is that you transfer to the nearest available bed, and that may mean that's not within your health board boundary.
Thanks, Andrew. I'm going to bring in Maynard and Donna.
Thanks, Chair. Andrew, given the fact that only 5 of our 9 funded posts are filled at the moment, and given the pressures we know are constant in critical care, are we in danger of losing any more staff? And at what point does the service actually become unsustainable?
So no, as I sit here now, we're not aware that we're going to lose any more of those 5 of 9 staff that we've got available to us. So that's why we're making the proposal that we are through to January, because we're confident in that position holding. I don't have, because there's so many factors involved and so many conversations we have, I don't necessarily have a lower threshold in mind as to what point the service becomes unsustainable, because if we were getting to the point whereby we were losing more of our medical and consultant staff, we would need to consider the whole model across the health board. It wouldn't just then be a Carmarthenshire issue and conversation. Carmarthenshire and Glencwilly is obviously our biggest critical care unit and serves the biggest proportion of our population. So it's obviously one that within any planning or solution we put forward, we would want to ensure remains sustainable. So it's something we'll continue to monitor really closely, Maynard, but I don't anticipate that we would get to that situation over the course of this winter anyway.
Thanks, Andy.
Donna.
Thank you, Chair. I think the comment from the CHCs, we're just concerned that the extension of a temporary service change, it's effectively what happened to children's services in Pembrokeshire, and it's quite destabilising for staff. They worry because there is no concrete future for them, and that's our concern, is that if you can't recruit by January, are we going to be looking then at a further extension? And at some point there needs to be, you know, a decision. Thank you, Chair.
Thank you, Donna, and I completely understand that point and the question, and it's something I've raised myself with the team in terms of at what point does this then become a permanent, a need for conversation and process to determine a permanent redesign of the service. I think the view at the moment is they don't want to make that call because they still want to push on the recruitment. And they still want to have another go over the next 3 or 4 months of trying to get additional bodies in to make the service more sustainable. It's not in their clinical plan, if you like, in this period that they would want to maintain it in this way. I think we would need to start signalling or start coming to a view over that second half of this year. If this looked like a recruitment position that wasn't going to shift or improve, that's probably the point at which we need to start thinking about what we would do in the medium term. But I think there's a couple of key things at the moment. One is we're not seeing the number of transfers that we anticipated. So actually the patient impact has been much lower than we expected. There is a conversation between the critical care team and the physicians in Prince Philip too around what level of support they cite that physicians believe they can provide to this service as well to try and maintain even more patients in Prince Philip and have a lower impact. So there's a few variables that we still want to work through over a longer period of time before we would want to take a judgment that there was a definite change going to take place. But I am very mindful, and I was very mindful in coming to the board today with the paediatric conversation as well, and the way the discussion we've had over time on that is that this would be an issue that we need to consider and think about over this next period.
Thank you, Andrew.
Thank you, Andrew. And I think that, you know, there's assurance here that we've got specific dates as well to revisit rather than it drift. So, okay, thanks, Andrew. The board's happy to accept the recommendation. Diolch yn fawr. Thank you very much. We're now going to go. First of all, can I apologise because I know we're running late, but everything that we have considered needed due consideration, and I think, you know, we'll continue to do that. So we're going now to the primary care update, and there's a number of papers for us to consider. So I'll hand over to Jill to do the general medical services and access bits.
Thank you, Chair. And I think really importantly, the next set of papers are going to really focus on that issue of access to services for patients. And Chair, you reflected just earlier that as you were going out talking to groups of members of the public, they're recognising the strategy, but very much wanting to understand the here and now and how they can access the services that are available to them. We are required to report the access standards and outcomes to our board. We are expected to have an access working group, which we do have. But just a couple of points that I did want to pull out of the report, which I hope is self-explanatory. First of all, the access standards sit within the General Medical Services contract, but they sit under the Quality and Improvement Framework, and on that basis, they're voluntary. And it also means that there are no minimum standards with which we can monitor practices on that. It is pleasing to note that this year, as a result of the uploading of that evidence, which is on a self-assessment basis, 93.8% of our practices did achieve all of the standards that are set within that framework. The important point for me, though, is how does that translate into reality and the experience that people have when they're trying to access general medical services. And we do hear many concerns, as you know, on an ongoing basis about challenges of accessing services, particularly post-COVID. We also know that there continues to be a range of options available for people to access remotely, for telephone triage, but also face-to-face appointments are extremely important where they are appropriate. And I think it was really important to note then that the Community Health Council have really focused on this with a survey that they conducted recently, and we have fed the outcomes of that back and the common themes that have come out of that survey across our localities. I think I do want to reassure members of the public, though, that where we are seeing significant problems, and we have some practices where there have been some very long-standing issues around access, whilst we're not able to hold practices to account through the quality standards themselves, and what we have sought to do, because we've seen some quite significant issues that we know we have to work with practices about, is we have had to serve a remedial notice by using a contractual breach on a failure to deliver essential services, which by that very nature means that access has been affected. So we have done that in a case recently, and we're working with that practice on an improvement plan, which they have to submit to us within 28 days of that notice period, and looking at the actions that they're putting in place to address significant issues in terms of their call handling and the availability of appointments. So really, I just wanted to bring this update to the board today, setting out the positive issues of achievement across our practices. The feedback from the Community Council, Community Health Council survey, which really gets to the nuts and bolts of people's experience of access, and the actions that we are able to take in a constructive way to work with practices where we see there are significant problems.
Thank you, Jill. I was surprised when I read the paper that it wasn't mandatory, the access, and that makes it much more difficult for us as a health board to ensure that the people who need services can get them quickly. But I hear what you say about we do use other methods, but sound quite laborious and quite draconian.
It's something that we've continued to work with Welsh Government on, and I think the Minister herself actually was surprised at a recent visit when we had that conversation. But it's something that we continue to work on, but we know how important this is in terms of access to services. So and it's a regular conversation at all of our meetings with our clusters and our localities in terms of how they make that access available and through different means.
Thanks, Jill, because there's such a variation.
Judith? Yeah, just to add to that, it's something that the Vice Chairs drew to the Minister's attention in terms of when we were discussing, which we do in our regular meetings, about primary care and access. And I think that, again, was a surprise, as Jill has indicated, that it hasn't been included. My question actually is, not for now, but I think it's fine in one way, the percentage that have achieved it, but what we don't know here is the number of people affected by the practices that haven't. We know there's a variety of the size of patient lists of practices, so we could be talking about 4,000 people affected, which is a lot, but we also could be talking about 20,000 people. So I think maybe I would be interested, and maybe it's a discussion I could have outside, around how many people are affected by the fact that two practices don't have this in place. It's important, however, the number, but I think it's the magnitude of the task to try and get the practice to that stage that we just need to be aware of.
And with the telephone systems that are expected to be in place now for these standards, there's a lot of data that we can pull off and look at that in terms of numbers, but also we can do that review, Judy, because you say in terms of what appointments are available, etc. So we can perhaps bring that back into one of our subcommittees.
I think that would be really helpful because it has such an impact on the general population. Are there any other questions on the GMS contract access? No, well, thank you. We've noted and taken assurance and raised questions, and thanks, Jill. So the next item on the agenda is dental services and access.
Yes, thank you. And again, I was asked to bring this report to the board on the basis of a lot of concerns again that get raised about access to NHS dental services. I think dental services coming out of COVID was the last one clearly to get back into that recovery state, based on the fact that as people will understand, dental procedures are aerosol generating procedures. So there was that delay really in terms of getting that capacity back within our services. But we were expected during last year to achieve a level of performance. We achieved, I think, 46% of our recovery. So we did make some progress, but as the paper sets out, that was quite variable across our different practices. We've also had very recently contract reform introduced, and 80% of our practices have signed up to the new contract, which does mean that there's a more targeted approach to a more holistic oral health and wellbeing approach, rather than the UDA mechanism that we have, which 20% of practices will still deliver. I think the key thing that stands out in this paper is the issue around urgent access activity. And you will see that the urgent access availability which the Health Board provides has seen a significant surge in demand. And that's partly because of the difficulty of perhaps accessing NHS capacity, but also people's inability to now pay for perhaps private services than they did before. And for 22-23, the paper sets out that we're actually having to increase that capacity and availability by 32%, making 6,050 appointments available for urgent dental access. I'm hopeful over time that with the new contract, which will also utilise an opportunity of 30% of that activity, providing access, urgent access services to patients, that we will see a decrease in the demand for that urgent access. But it is something that is a cost pressure to us, but something that we recognise is important in terms of the ongoing availability of access services for our patients. And we do also have now a mobile dental unit, which is on our Houghton Derwent site, and that's now providing additional sessions every day of the week from this month. There are some positives in the paper though as well, and I think the performance around our orthodontics waiting list, which we again know has been a significant challenge over recent years, but we've seen a reduction in that waiting list and an improvement in performance. So whilst there is still a long waiting list of 3.2 years, that waiting list has decreased, and it is 2,800 individuals are on the waiting list, still too high, but we have seen an improvement in that performance. And then the other element I would like to perhaps highlight is the issue of the paediatric specialist trainee that we have employed, working with Swansea Bay University Health Board to support us in the development of that post. We expect to be able to repatriate some of the services, the tertiary services that we commission from some private units, but also from Swansea Bay back into our health board in due course. So again, this is a very emotive issue, and we know that our telephone lines into the hub are still very busy around NHS dental access, but this sets out the current position. I'm sure will be something we'll report on again in future months.
Many thanks, Jill. Could I ask two questions? You mentioned the increase in the emergency provision that we as a health board are providing, over 30%. Do we have the capacity to do that? And then the other question I have, what do we have the trajectories to improve performance, particularly in those areas with long wait lists?
We've got certainly in terms of data in dental services is quite advanced, to be honest, and we get a lot of information from every dental practice in terms of their performance. So there is opportunity to work with practices around improving improving that. In terms of the issue around our urgent access, we've had to recruit additional staff into our internal teams to be able to support this. And it's at a cost pressure to the organisation in terms of being able to deliver it. But I think not to be able to have those urgent slots would be, a serious issue for us, because we're not able to be confident about capacity that's out there within services. I would like to say, though, that we do see some failure to attend for appointments that are booked. So I want to encourage people that have got those slots booked to turn up, because it means the slots aren't available for others. But there's also an interesting information that we gain from that in terms of people's behaviour around the use of dental services. And normally when you use an urgent access slot, you are offered, if appropriate, a course of treatment beyond that initial appointment. Many choose not to have that course of treatment. The risk being, I guess, that they will deteriorate again, require a further urgent access, and so the problem doesn't get resolved. But I think many people now choose to use dental services in that way. So again, it's something that we're using to try to identify how we best provide services for the population.
Judith?
Yeah, thank you. It's really helpful to have the update. So thank you, Jill, and the team for preparing it. The Vice Chair's had a presentation actually from the new Chief Dental Officer, which was really welcomed. But one of the questions that I actually asked was about dental training, because I know from my previous role that when I was working, that there is the dental hospital in Cardiff, full stop. And I did ask about any plans to expand the capacity to have dental training elsewhere, particularly maybe in West Wales, linked to one of our universities. And he was open to the idea, although there weren't any plans. So I just want to flag that, because I think it's something through our various arrangements, our links with universities, that we do pursue, because a bit as we do with medicine, if we know somebody's trained and they have a good experience, and we've got a new nursing school in Aberystwyth, then they are maybe likely to stay, whether that means with our own service or going into one of the practices. So I just wanted to flag that to the board, and I think Jill and I can continue discussing.
I'm pleased to say that level of openness has continued to the point. We have a meeting this afternoon with the Chief Dental Officer to talk about the opportunities of that. But it's a really important point, because I didn't pick up recruitment. We did not get dental training places this year. They weren't filled to come down to Harvard. So, that's a really important point for us in terms of our ability to sustain, to encourage, and when they're here, they're likely to stay. But if we can't recruit the trainees, and the practices were ready for them, but they weren't filled. So it's an important point.
Yeah, that's a very important point that the board would support this afternoon's meeting. And Steve and I are at the opening of the new nursing school in Aberystwyth tomorrow. I think there might be an opportunity to raise that there as well. So thank you. And the board's happy to accept the recommendation, and thank you for bringing a really important paper to the board, Jill. So the next items of the agenda are the primary care contractual applications, and the first one we have is Nayland and Johnston practice.
Thank you, Chair.
Can I just declare that I chaired the vacant practice panel, and perhaps I could come in to say after.
Thank you, Judith. Thank you.
Thank you, and I confirm at the outset that this is a decision item for the board today, and the opportunity that I'm taking at this point is to update the board on the position that we're in and the outcome of a recommendation from the vacant practice panel that has met to consider the issue. So it's really important that the board takes the time, and I'm sure people will have gone through the paper and all of the annexes that have been made available in coming to a decision today. And again, just stressing the importance of services for patients in their local area as I set this out. You will see from the paper, from the context, is we found ourselves in early July in a position of receiving a contract termination from a practice which, just prior to that, the receipt of that process, had become a single-handed practice. And that meant, therefore, that the timescale in responding to that contract termination was much reduced from 6 months down to 3 months. And that, therefore, required a very speedy response from the organisation to be able to respond to a point that we could understand what the services would be and should be from the 1st of November. So we are required to go through a formal process and to establish a vacant practice panel, which met initially on the 22nd of July, on the 12th of July, and to consider all the issues. And if I can just remind the board that the opportunities open to the health board in receiving contract termination are to support another practice or contractor coming from elsewhere to take that practice over, to take it on as a managed practice, or to disperse the patient list. And we know from the paper there are 6,000 patients thereabouts registered with the Nayland and Johnston practice. Because of the timescales, we couldn't go out to the open market, but there was an exercise conducted with local practices in the area for expressions of interest in taking that over. And clearly there was not a response of that interest. So the vacant practice panel had to consider the issues, and they came up with a recommendation that would look at a partly managed practice for the patients resident around the Nayland area, and dispersing the remainder of the patients to the Nayland from the Haverfordwest and Milford area to alternative practices which actually were nearer to their home address. CHC and LMC are also involved in this process. Now, we were aware of that initial consideration in a closed board setting, but it was a point in time because what hadn't happened by then was the patient and public engagement. And that's a critical point or part of any process such as this. And I know that we are a listening organisation. We pride ourselves in listening to members of the public and patients in this respect. So there was significant patient and public feedback, and that period went on from the 1st of August to the 2nd of September. Many opportunities were available for patients to respond from hard copy, email, text, all sorts of opportunities. And there were also virtual patient and stakeholder events conducted. We had a number of political meetings with local and national politicians, and we had several meetings also with the LMC and local practices. And we clearly worked with the CHC, who've been supportive in assisting us with the process around this engagement. All of that information was collated prior to the CHC executive meeting on the 5th of September. And at that meeting, the CHC considered their findings, and they felt that they could support the partly managed practice, but had concerns around the element of dispersal, and also raised the issue around appeals for those who would be dispersed. We also know that the LMC declined, or they chose not to support the VPP recommendation at that point, and fed that back into that meeting with the patient and stakeholder feedback. And there was also feedback from neighbouring practices that felt very concerned that dispersing patients to them when they were already under challenge would be an issue for them around their own sustainability. So all of this information was fed back into that second vacant practice panel meeting, which took place on the 13th of September. Now, clearly, the VPP had to consider everything in the round, and there are ongoing concerns in the ability to staff clinical rotas for the managed practices as we know them now. And there are real risks some days in those managed practices around no doctor days. So it was important that the vacant practice panel also considered the challenges around clinical staffing, not just doctors, but other professionals as well. They also needed to take account of the premises that we had available to provide those services, so that the decision that that would be the recommendation would be very much based on the feasibility and viability of whatever the VPP proposed. So taking all of those issues into account, the outcome of that VPP practice, of that VPP recommendation on the 13th of September was that they upheld their initial position, that they would look at a managed practice for those residents around Nayland, and recommend dispersing about 2,000 patients to alternative practices. We know that we've had some challenges since then, and I think the other thing that has come to light, the other important factor that we have to consider, and I would draw the board's attention to this, is the longer term strategic viability of a smaller entity. When we were at the point, probably might have been 2016-17, 2,000 patients actually came across from Argyll practice at that point. And it was a really important point for those patients into Nayland. And at that point, we talked very much around the importance of strengthening the viability of what was then a smaller practice up to that 6,000 patient number. So one of the questions the board does need to consider is that issue around the longer term strategic context of attracting individuals to work within that smaller facility, multi-professional team members thinking about different models for the longer term, even APMS contracts, GMS contracts, because whatever the outcome, a managed practice is always meant to be a short-term fix. I know one of the other things that we considered was the challenge around premises, and both the Nayland Johnston buildings are very small. And we know that in terms of the challenges of supporting 6,000 patients out of one of those buildings would be an issue. But we believe that there are opportunities to utilise some neighbouring accommodation in things like the Pembrokeshire Hub, or looking for other local solutions that may be available for either administrative purposes or for clinics that don't require a treatment room type facility. I think it's really important, and you know, I just want to absolutely assure members of the public who are listening to this today that this is the fresh opportunity for the board to consider all of the issues, including the recommendation made by the vacant practice panel, and those wider issues that we know are so important to the local community. I'm sure that everyone will have taken time on the board to have gone through the feedback that we've received from members of the public and other stakeholders, and that now I ask you, Chair, for the board to consider all of these issues and come to your recommendation.
Thanks. Yeah. Tricia, do you wish to speak now?
If I may, actually, I think it's probably timely because I think just to say, when you chair these, that it is always difficult, and I was always very clear as a chair that as far as I'm always concerned, we don't want to be closing practices. So although that is potentially always an option, it is about what can we do to do that, to avoid that. And also, you know, as chair, and the whole panel relies on the advice that's given by various members there to consider. And I think what I do need to say is that since that decision, I have been aware of potential options or potential solutions that may mean that actually there were other things to consider, such as Jill's mentioned, potential for alternative accommodation that could be used within the area, and also that there may well be other medical staff who are willing to come forward to support a managed practice. I think, therefore, I do need to say that under normal circumstances, if we'd had more time, I think that information would come back to the vacant practice panel. Now, for the reasons Jill's outlined, we don't have that. So I think there's a role for the board to consider the process around this because of the new information or the additional information that's become available. And Phil may want to comment on that because of some of that relates to the medical input. The other thing I'd say, it may be an additional recommendation, I think the process needs a review. I think we are within a process that has been set some time ago, and I would therefore really want the board secretary, probably working with Jill, just to have a look at that to see whether that really does fit the way we want to move forward, because it does tie you in to certain processes that are a little bit inflexible. And I think if we had full control, we might do it slightly differently, but I wouldn't want to go outside any governance rules. So I would ask if that could be considered as well.
Thanks, Judy. I'll go over to Phil now, if I may.
Thank you. Just to confirm that I wasn't part of the panel process, but since the process, I have spoken to members of the senior medical team, primary care medical team, and other colleagues, and just to support what the Vice Chair and Jill have said, I think new information has come to light since the panel, and we are on a, you know, this type time scale. And that new information does relate to accommodation that I don't think the panel was aware of at the time, that could be really important for to be able to care for patients in a GP surgery in that area. And the other information is that there has been some interest from GPs coming forwards to help staff that practice. The only caveat I would say is that at the moment we would still need more GPs than we've got committed at the moment, so that still will be work in progress. But I think from my perspective, given the information contained in all the attachments and all the feedback we've had from the public, the LMC, surrounding practices and others, and CHC, and given the fact that this is such an important decision, as Jill reminded us, that going to a level of 4,000 population for a practice does then lead to questions about the medium to longer term sustainability of the practice. I think given this new information, I think we need to really reconsider that from my perspective, that recommendation.
Many thanks. Thank you, Jill and Judith and Phil. And there's a comment from Chantel. It says, it seems that we should also be looking into longer term solutions. Do we have any data of the number of GPs who will be retiring in the near future, given that it appears that the independent contractor provider does not seem to be that attractive to younger GPs?
This is talked about at a national level, to be honest, and we look at many models in terms of salaried versus GP independent contractor status. I know the LMC and GPC Wales would absolutely advocate to that independent contractor status, and I think what I would commit to at this point is that, you know, we're open to looking at a range of models that will suit our area. And I think there is an importance in terms of retaining that independent contractor status if we can, and where we can, but also looking at how we create the opportunities for portfolio careers with salaried GPs, but also actually, again, as part of the strategic primary care model, we're encouraged to also look at alternative providers of medical services as well, and how we would open up that opportunity. So there is data at a national level. We have workforce data which all of our general medical services practice have to update on a Welsh national workforce tool. So again, yes, Chantal, we can get that data out, but as you say, younger GPs have different views around the way they want to work, and I think we need to look at those flexible opportunities to create the future model we need.
Thanks, Jill. Are there any other questions from members? Okay, if I may summarise, if that's okay. Thank you, Jill. You've given us a very detailed summary of the history, the very short history, because of the time period that was imposed upon us. And Judith, thank you. You've set out the vacant practice panel, and Phil and Jill and Judith, the information that's come to light since the vacant practice panel. Now, ideally, with the new information, we would refer that back to the vacant practice panel, but the GMS contract expires on the 31st of October, which is only 5 weeks away. And as a board, I'm sure we'll all agree that the patients and the staff who serve those patients in Neyland and Johnston, the neighbouring GP practices and the community need certainty now.
Yeah.
So as a board, we've listened to the new evidence or the new information about the opportunities to use new premises, the interest from GPs coming forward to assist in the practice, the longer term strategic context, so it's more attractive as a 6,000 patient practice to GPs now and in the future. and the history about we made it sustainable with this number historically. So that looking back to look forward, and it would appear that the sustainability that 6,000 patients size is really important. Every single board member has read, as did the vacant practice panel, all the appendices and the feedback. So this is new information, but reading the feedback, and as you said, Jill, we are a listening board. The overwhelming feedback from patients, the neighbouring GP practices, the LMC and the local community council is to retain the practice as much as possible as it is. As the sovereign body, the health board can take a decision and has a duty to do so in these circumstances for the reasons I've outlined. So following this discussion and the new information, can the board confirm that its decision is to establish a health board managed practice for all the current registered patients at Nayland and Johnston surgery? And we must recognise that there is a risk that there may be some days where there's a challenge with GP cover, but that risk is the same with a 6,000 practice as it is with a 4,000 practice. But the other information, I would say, outweighs that on the balance of probabilities. We agreed to review, as you've suggested, Judith, the governance in primary care, because it's been there for a long time. We've learned, and you know, from a number of times that we've had a vacant practice panel, that it is a very good time to review it. So that would be with Jill and the board secretary. Are there any other, anything else we would like as part of that board decision?
Could I just ask that I think if that board decision is there and it's something that we need to consider going forward, I think it's the capacity of the team, to be honest, in terms of the way in which we can manage practices.
Yes.
And I think that's something really important.
Yes.
You know, taking on a 5th managed practice is a challenge.
Yes.
But we want to do it well and appropriately to support patients.
Yes. Okay, can we also include, if this is the board decision, a recommendation that as an organisation we consider the capacity of the primary care team to absorb and manage, for the sake of the population, another practice in Hywel Dda, particularly as we know from previous papers the number of GPs in Hywel Dda have drastically reduced, although we're very innovative with different models of primary care provision. Are the board happy to accept that, and that is the board decision? Thank you. And I'd just like to say a huge thank you to Jill, to Judith, to the primary care team for responding so thoroughly and so quickly to a situation which was not of our making, and to do the best that we can to serve the population and the patients of Nayland and Johnston. So thank you very much. Thanks, everybody. So the next, it's another primary care application, and I think that's Margaret Street is next.
Yes,
Over to you, Jill.
Can I also say I chaired this one as well?
Thanks, Judith.
I don't need to come in on this one.
Okay, thanks, Judith.
Thank you, Chair. And this is a branch surgery closure application. The application was made by Margaret Street Practice as an application to close its branch surgery in Cyhoeddus, which is 1.5 miles away from the main site. Again, we followed the formal process that we are expected to do and set up, with the support of the CHC, a branch practice review panel to consider all the facts. And you know, in the previous paper as well as in this one, we've got now very sophisticated patient modelling data, which allows us to look at where patients are, how they're able to access services. So there was an engagement process taking place between the 9th of May and the 24th of June to talk to patients virtually and through other means to find out what their thoughts were. It was quite an open question to see from the paper in terms of their thoughts around the closure of Cyhoeddus branch surgery. The feedback that came, there were some consistent themes related to transport, parking, appointments at the main site, capacity at the main site, ease of access for local communities, and the real concern around loss of services at a time when we're promoting care closer to home. And I think in addition, it's also important to note that a petition was received by the Health Board of 1,822 signatures, which opposed the closure of T Cross. CHC held an executive meeting on the 30th of June, and then a further branch surgery panel met on the 12th of August to consider all of the information. And at that opportunity, you'll see again from the paper, the practice has the opportunity to present its position as well in terms of the risks that it feels in terms of maintaining the appropriate cover for that branch surgery. And again, you'll see within your paper the criteria that must be met by all practices who are recompensed for opening a branch surgery, minimum of 20 hours, but it doesn't always need to be GP type services there. It can be arranged at other clinics, but it's expected to operate over 20 hours a week. And we do note that the practice advised that they had to close that branch surgery during COVID, but it was used as a red site, and it hadn't got back to fully working, I have to say, as a branch surgery over the subsequent period. The branch surgery practice panel review meeting considered all the facts, and again the petition and the feedback from patients. But they felt that overwhelmingly at this point in time it was going to be very important for that local community, for all the reasons that have been raised, to retain the T Cross branch surgery open as a fully operational branch surgery for the 20 hours a week. There were conversations with the practice about how they utilise and optimise the team that they have got available so that they don't destabilise their clinical team and utilise to best effect the services that they can provide through that branch surgery site. So the branch surgery review panel meeting made a recommendation to the board that the application is turned down, and that the recommendation is made to retain that branch surgery for the 20 hours a week. And that is the recommendation that's coming to the board today, again for your consideration and decision.
Thanks, Jill. Are there any questions? I have one question. Should the branch review panel be part of the governance review?
Yes, I think one of the things, if I can just say,
yeah,
we used to have a meeting, and I know that some board members did find it challenging, but there was something called a PCAP, a Primary Care Applications Committee, which formerly sat as a subcommittee. And I think what we're seeing through these situations now is that there's perhaps a gap in our process, really, in terms of being able to utilise something such as that.
Okay. Well, the board happy to accept the recommendation, to note the recommendation of the branch surgery panel ratifies recommendation that the health board doesn't agree to the closure of T Cross branch surgery, and also to review primary care governance as a whole, as opposed to just the different panels, and that would bring in any committee issues. Thank you, Jill, and thanks again to all the team. The next item on the agenda is the respiratory vaccine programme. This has been discussed and scrutinised in detail at the SDOP committee. Don't know if there's anything you want to add to the paper, Alison?
No, thanks, Chair. I think it's self-explanatory, to be honest, and Bethan's happy to answer any questions from anybody.
Hi, Bethan, thank you. Welcome. Any questions on this? No, well, I think based on the most incredible rollout of the vaccination programme to date, which has saved lives, a massive thank you to you all. And the board happy to accept the recommendation. Thank you so much. The next item on the agenda is the decarbonation report. Over to you, Lee.
Thank you, Chair. Yes, and as board members know, obviously decarbonisation, the climate emergency is a significant challenge and issue for society overall, and where we've got a very important part to play in that, of course, and we're very committed to it as an organisation, and I think this delivery plan hopefully sets out some of that ambition. Just to give board members context, Welsh Government published its delivery plan in March 2021 with the ambition of reducing the 1 million tonnes of carbon that are currently emitted as a consequence of NHS activities across NHS Wales by 34% by 2030, and an interim milestone of 16% by 2025. So the plan we're providing today is seeking to answer the question of how we might respond to that delivery plan, and in particular the actions we can take and the roadmap to that 2025 interim target. Within the report, there's quite an extensive action plan setting out the key areas that the work is being delivered in across the state, transport, procurement, and of course the approach, the way in which we deliver healthcare. What I would say though is that it is an evolving piece of work. Naturally, we should see this as a point in time assessment of where we are and what we're proposing, and this will develop naturally as we go through the next period of years. The key message that I think board members can take from the report is that we do anticipate reducing our carbon footprint across over the coming years. That is the trajectory that we're on. And that's reversing obviously previous trends. Equally, the report is concluding that it is possible for us to achieve that 2025 milestone and potentially the 2030 target as well. The key question for that on that though is on the capital funding required to support that, and there is ongoing work on the baseline assessment of the carbon footprint as well, which could change the starting point, if you like. We are, I think, one of the only health boards, if not the only health board in Wales, to have actually costed our plan, so that's helping the discussions nationally to understand the choices that we've got as a country and what we might be able to do as a result of that. So I'll stop there and invite questions and comments. The one thing I will just say is, on a positive note, is in the last month we have our clinical teams have now completed the work to cease the use of desflurane as an anaesthetic gas in Glangwili and Prince Philip, and because of the impact that has on greenhouse gas emissions, and we're now moving on to other areas to look at the opportunity with nitrous oxide as well. So there's a lot of work going on that this report can't really give full justice to, if you like, because it's just touching the strategic plan, but some good progress across clinical teams. Thank you, Chair.
Thanks, Lee. And the stopping use of those gases, you mentioned 2 sites. Is it going to be across all the sites?
Yeah, so it started, and this is about capturing clinical enthusiasm, I think, for change. So we've had that enthusiasm in Glangwili and Prince Philip within the anaesthetic and theatre teams there. So the intention, yes, absolutely, is to roll that out to the other sites. But it is a process of change, and that does, there's hearts and minds to be won over as part of that.
Okay, thanks, Lee. Winston?
Yeah, Chair, I'm probably thinking it may be good if Dr. Phil Kerr had an opportunity to say his comment, and then I'll come in with my question, which is quite comprehensive.
Okay, Phil?
Yep. My point. I mean, Lee's mentioned stopping the desflurane, which is great. I think there's a temptation with decarbonisation work to focus mostly on transport and estates and procurement and things like that. And actually, it's sort of more intrinsic to every aspect of our business, and particularly all the clinical pathways. There's so many aspects to it, and as Lee says, there's a process of change and winning hearts and minds. We did have a presentation yesterday at our medical leadership conference, which was about that, and there was a huge amount of enthusiasm for that, and I think probably there's a big link here to value-based healthcare, because actually the cleanest and greenest pathways are likely to be the highest value as well, and if the more we can link those, the better. So, you know, Lee and I have had conversations about this. Hopefully you can build on the enthusiasm from yesterday, but really good to see the plan.
Thank you. Winston, I'm going to go to you, but I've just had a note to say that HEIW have to leave in 10 minutes, so I'm going to ask if you can make it quick.
It's a bit quick. It's a bit quick.
Thank you.
Firstly, I really welcome the plan. I really welcome the fact that we are one of the first health boards to have costed it. I think the Carbon Trust report, which is some 80 pages long, and the executive summary really captures it. It says that we need to make a step change in order to make this part of our everyday work. And I think this plan is really good in linking to Welsh Government targets, and my but is there's more we can do. So procurement currently forms 58% of our carbon footprint, but if you look at the action plan, The action plan is excellent with estates, excellent with transport, but the procurement area needs a lot more support, I think, to be honest. So what I'm saying is I support the plan fully, but I look forward to in the SRC committee, which overlooks this planning objective, for how we can do more with procurement and the estates team to really make this plan hum and tick. And Phil's point is absolutely right. Because my question was going to be about clinical engagement and operational engagement. I'm sure there's a huge amount of enthusiasm across Hywel Dda, and I think the opportunity is there for us to take.
Thanks, Winston. I think Lee's agreeing.
Yeah, and just to say, obviously, we've got shared services as part of our working group as well, and a lot of connections to them, and that's they're obviously the key part to delivering the procurement opportunities. But Winston's absolutely correct.
Thank you. Thank you very much. Is the board happy to accept the recommendation? Diolch yn fawr. I'm going to welcome Rebecca Jewell from HCIW now. Rebecca, many apologies for bringing you in late. There's an absolutely packed board agenda today, and we will be scrutinising the HIW report at committee level as well. So I know you circulated a summary yesterday. I just wondered if we could, you wanted a quick introduction, and we'll ask questions if that's okay.
Yeah, that's absolutely fine. So hopefully you can hear me okay.
Yes, we can.
Yeah, thank you very much for giving me some time today, and I've been listening in. It's been a really interesting session, and I agree completely. Lots of really very important updates, and absolutely vital that they all had the discussion time they needed. So I don't really want to take up too much of your time on this. I have circulated a presentation. You may or may not have had time to have a look at it, but time is very tight for everybody today, and this may be something that I could perhaps come and deliver to board at a different time, perhaps, because it's really important, I think, to HIW that we continue to raise awareness of how we do our work and how we carry out our work. So I think that what I'll do is just draw your attention to the view of HIW that we've published as part of the report for the 21-22 year. And I think what I want to highlight is that we very much recognise a year again of continued pressure. And the themes that we've seen within Hywel Dda, they really are the themes we've seen across Wales. You'll notice within the presentation that we have broken down the numbers of work. So across Hywel Dda, there were 21 pieces of work, but across Wales, obviously the number is a lot higher, closer to 200. So when I talk about themes in Hywel Dda, they are based on not just our inspection and assurance work, but also concerns that we receive from members of the public, from whistleblowing potentially. We monitor the safeguarding referrals that come through in relation to the health board, and obviously we monitor the data in terms of no surprises, serious incident notifications, etc. that come through. So for Hywel Dda, I think it would be fair to say that we've continued to see a really strong focus on the learning culture, and that quality is very well embedded in the leadership of the health board, and quality is a very, very big, not concern, but a very big area of focus for HIW. We've noted, I think, that across Wales there are issues in unscheduled care particularly. I think that's an area where in general we've made more recommendations than in scheduled care. And I think it's really notable to mention that, because within scheduled care, where that control is much more possible, it may well be that to achieve higher levels of infection prevention and control, for example, you have to actually also slow the flow down, and therefore that may well have an impact on waiting lists. That's not something that we have evidence of, but I wonder whether that is contributing. So of course the challenge for you is where you can't slow that flow down in the unscheduled care areas. It's much harder to manage, and we recognise that very much. So I think that if anybody has any questions, it would be a good time for me to answer any of those, any particular comments on the report, and hope that the board feels happy with the view of the Health Board that we've presented as a result of our work over that year.
Thank you, Rebecca. Do colleagues have any questions? Mandy, thank you.
Yes, thank you, and thank you, Rebecca. And it's really pleasing to see the positive comments around particularly around the embedding of the approach that we're adopting within the organisation around quality and safety. I suppose the only comment I would make is that it would have been helpful, probably, had we had the opportunity to see the report and take it through our quality committee for further discussion and scrutiny prior to it coming to board. I'm sure there's a reason why it's come straight to board as opposed to going via our board committee structure, but I do know that the report in the brief time that we've had sight of it is already considered and will be played back through our quality committee at its next meeting. So it was just an acknowledgement, and thank you for recognising the hard work, and just to provide members of the public who may be observing this, that the areas that HIW have identified are all areas that we are working on actively to try and address and improve further the approach that we deliver, in the way in which we deliver our services. So thank you.
Thanks, Mandy. That's great.
Sorry, Rebecca, did you want to just?
Yeah, I mean, I was just going to say, in terms of timing, we have been pushed this year by the launch of a new strategy, and so in terms of timing, I think that this may well be that we have missed the opportunity to bring this to a board committee meeting ahead of the public board. So apologies for that. I think that we'll be publishing much earlier next year, and it should give us the opportunity to bring it to you in a better way. Yeah.
Thanks, Rebecca. That'd be really helpful. But we will be taking it to our Quality and Safety Committee for in-depth scrutiny. I just wondered if that's the appropriate place, if you've got time to come back.
Yeah, more than happy.
Everyone will be able to consider.
More than happy. Great. Yeah. I think that it is worth noting that previous annual reports, we have drilled down into the themes that we found in our inspections, quality checks, specifically of each health board, but really with the numbers that we're looking at and the fact that we're balancing our work all the time. We have a programme that we start the year off intending to do, and then depending on risk, things go in and out of our programme in accordance with what we're concerned about over the year. And so what we've done here is it's a much more overarching view of the health board that we've provided in this report. It doesn't just take into account our inspection and quality check findings. So it is a little bit of a different focus.
Great, that's really helpful to contextualise it. Thank you so much. And if there's any questions, I know you've got to leave in 2 minutes as well, so apologies for that. So we'll come back about the Quality and Safety Committee, and that would be, have an opportunity then to consider. Many thanks. Take care.
Thanks a lot. Bye now.
Rebecca has a standing invitation to attend our Quality Committee, and it's on the next agenda already.
Oh, that's great. Thanks, Joe. So if we go on to the next item on the agenda, we're not going to take the Director of Public Health report at this stage, but we will do it a bit later on in the meeting. I'm going to go through the I'm going to go through the assurance committees, and if there's anything that chairs wish to raise, because we have read the papers, please do. Winston.
Good afternoon. There's only, I think the reports more or less speaks for itself. Just going to highlight a few matters for the board's attention, some of which we've already heard earlier in this meeting. The first item that I just want to highlight is the potential deterioration of the health board's underlying financial position due to the non-recurrent nature of savings. And that's the first thing I want to highlight, that as our savings are delivered this year, a lot of them are non-recurrent and therefore has an impact on our next year and the year beyond's position. The second thing I just want to highlight, which Hugh has mentioned in his update, is the treasury management cash risk that we face, which is more of a short-term issue for this year. And Hugh's already explained earlier that at the next board meeting we will have a mitigation plan to to address that situation. And that's quite key because we don't want to run out of cash before the end of this financial year. And a couple of the more positive things, we received some positive assurance in relation to value-based healthcare, and some of the work that we're doing as a health board is quite innovative and it really engages our clinicians, so that was excellent. And another positive thing that we received assurance was in relation to some of the work being done on landfill usage and the carbon friendly inhalers in contribution to the health board's carbon target. So that's all, Chair and board members, I want to just highlight in relation to the Sustainable Resources Committee. Obviously we retain a real focus on our financial position and our forecast, but this board meeting's already superseded what we discussed at the last meeting.
Many thanks, Winston. If I could go on now to the Strategic Development and Operational Delivery Committee. Maynard.
Thank you, Chair. The report is as it stands. Just want to draw the board's attention to the fact that when we met, we hadn't received a response from Welsh Government on our PBC for the new hospital. We have since received a reply. We just highlighted two areas of activity. One, they've asked, I believe, the Health Board to develop a strategic outline case, and two, a review of the clinical model with us, which I believe is already being kicked off.
Many thanks, Maynard. I could go on to the People and Organisational Development and Culture Committee. I think, Judith, you chaired the last one.
Yes, thank you, Chair. I did chair the last one. There's nothing I particularly highlight other than just to point out to the board that we did consider the Tritech business case in detail at this committee. I'm very conscious it's the next item on the board, and I'm happy to take questions. The only thing I would like I think I do need to point out, the committee have noticed the very high quality of papers that come to this committee. They really are excellent, and I think I do need to call that out to the board. We did make that comment to Lisa at the meeting.
Thanks, Judith. Good to hear. Should we go on to the Tritech business plan? And Philip Chew, and as Judith said, that has been considered in detail at the People Committee. Yeah. Bill? They recommended approval. Yeah. Thank you. You're on mute, Bill. Best today.
Apologies. It's been considered really carefully at the Research Innovation Subcommittee and at the People Organisation Development Committee. As Judith has said, you have the paper and the business plan. It's a really exciting initiative for us, which is gaining national attention and interest, and it is improved morale, I think, of clinicians who are connected with this. And so I commend the report and the business case to you. We are discussing sort of commercially sensitive elements of this in committee, I should say, but happy to take any questions, but it has been scrutinised and we're asking the board to approve the Tritech business plan.
Many thanks, Bill. Do we have any questions?
Just for the governance point before we approve, members have seen the commercially sensitive information, which is in committee, as Dr. Clare has already noted, but it would be the approval. We can't share that information because obviously it could detriment the Health Board's future working chairs. That's the only reason it's not shared with the public.
Thank you. So this decision is based on the whole of the information.
Yeah.
Okay. On that basis, the board's happy to approve the business plan. And thanks very much. It's really exciting. And thanks to everybody who's put it together. And the report of the Health and Safety Committee, Judith?
Nothing specific to raise. It's there for any questions.
Which is wonderful, isn't it? I'm just wondering, there might come a time when we might be able to stand it down.
Oh, well,
I'm not saying that.
No, whilst I would never volunteer necessarily to keep on with committees, but actually, I think, and I hope other members agree, I think having the focus, but also the opportunity for those staff to really have somewhere to bring very key issues for the Health Board. I would not advocate that we
That's
do.
Great.
Remove the committee.
Found your great judgments. Thank you. So now the committee update reports. Please say if you want to come in or that one of them's got an approval in there. So The RATs.
We do need to approve the RATs terms of reference when we get there.
Okay, next one, RATs terms of reference. Everyone happy to approve that?
Maynard wanted to come in.
Maynard, did you want to come in? Sorry, I missed you.
Yeah, it was just a very quick comment to congratulate Hugh Thomas on his professorship in Aberystwyth University.
Okay, many thanks. So I see your comment, Paul, and I understand. The remuneration terms and service conditions, terms of reference, are we happy to approve them? Thank you. Then we've got in committee boards, happy to approve that. These, I'm going to just do the abbreviations. SRG update, health professionals forum update, and SPF update. Thank you. And then we've got the joint committees, minutes. Board's happy to receive all of those minutes. Is there anything? No, that's fine. And then we've got the cochlear implant and bone conduction hearing implant service, device service. Lee.
And Chair, that it has been discussed at risk as well through where Steve is our representative there, but this is a specific approval item.
Okay. Lee, have you got anything to add to the paper?
No, I think it's self-explanatory, Chair. I'm happy to take any questions though.
Okay, any questions, members? Board's happy to approve. Thank you. And then the statutory partnership update.
It's self-explanatory, Chair.
Thank you. Happy to receive. Thank you. Board annual work plan. Thank you. When do we do the?
No,
okay, right. We thought we'd do now at the end of the board meeting. And of course, the public health annual report. Joe, I'm going to bring you in, please, if I may.
Yeah, thank you, Chair. So it's an absolute privilege to bring you the DPH annual report for 2021-22 on behalf of Ros Jervis, who was the DPH throughout the whole of that year and for the 5 years previous. Just wanted to say thank you to Rebecca Evans, who's a principal public health practitioner within the Directorate, for putting this together, and also thanks to partners and colleagues who've been interviewed as part of the report. And as a Directorate, we also just wanted to say thank you to the board and all members of the board for the support and guidance that you've given us over the past 12 months since Ros became unwell. And we miss her dearly, but we know as a Directorate, as a whole board, that her leadership has changed many of the ways that we look at things and how we move forward. And some of the gifts that she's given us are her resilience, her positive energy, and her can-do attitude. So hopefully this video will work now.
Thank you, Joe, and we all echo what you said.
It's a minute, we just a few technical challenges. Yeah.
Every year, the Director of Public Health at Hywel University Health Board is asked to write an annual report. Sadly, the Director of Public Health, Ros Jervis, passed away at the beginning of June 2022 after a short battle with cancer. The focus of this year's annual report is therefore a tribute to her leadership and to the wonderful legacy that she leaves, which will guide our ambitions to improve population health and well-being in the future. Inspired to work in Wales by the opportunities provided by legislation such as the Wellbeing of Future Generations Act, Ros arrived in Hywel in August 2017 with a clear vision for improving health and well-being. This vision led to the development of Our Future Generations Living Well, a health and wellbeing framework for Hywel in 2018, in which she described the need to shift resources to think about health and wellbeing in a more holistic way that went far beyond healthcare services.
Ros's legacy, I think, has been quite remarkable. She came into the health board at a time when I don't think public health was at the centre of our thinking. And actually, over the time she was with us, she completely changed our thinking, and actually not just ours, but all of our partners. And she really refocused the whole of West Wales on population health, on how we keep people well in a way that I don't think we could have done without her. So really remarkable input into the organisation, which I think will be felt for many years to come.
Ros knew that creating health involves looking across communities, culture, services and individual influences. This broad scope sits within the remit of the public service boards in each county and in the health and wellbeing plans that they produce.
In the development of the new wellbeing plan, when we're looking at the delivery of the new wellbeing plan, we had set 6 areas, 6 project groups to push that work forward. And I was asked to lead on the work around understanding our communities, and Ros was asked to lead on the social and green prescribing work.
One of Ros's real strengths lay in her ability to bring people on board, inspire confidence in a shared vision, and create equal partnerships that built on a shared purpose.
We worked together to organise a conference in Lampeter University around 2 years ago on social and green prescribing, where we brought key stakeholders interested in this area together, and hopefully the next couple of years we'll take forward that work.
She was really able to kind of put dots together, make sense of things, and to really play a role that transcended that particular role that she had within the health board. I would say really influential in terms of setting the agenda and developing some of the transformation programs that we delivered over a 2 to 3 year period.
Although, I remember thinking, although I was leading another project group, another area of work, I really wanted to get involved in Ros's area of work. And she had that nature, didn't she? She had that ability to get people on board. She really did have those kind of communication skills.
Ros had a genuine interest in talking and listening to people across organisations, communities and individuals. She wanted to understand what mattered to the people living in Hywel Dda.
Her vision to look at holding 10,000 wellbeing conversations with the public across West Wales is something that I know many of us want to achieve in her memory, because that is such an important, really does reflect the way she worked and the way she wanted all of us to work with others and with others influencing what we did.
In 2019, when the coronavirus pandemic arrived, Ros had to react swiftly and effectively to the greatest public health challenge in living memory.
Ros had a massive role to play in Hywel Dda's response to the pandemic, which, as we all know, was really worrying at the very beginning, when we saw what a mountain we had to climb in order to care for people and protect them. And Ros was absolutely phenomenal. So we saw each other a lot during that period, and she made such personal sacrifices, living away from her family in order to concentrate on serving and leading the pandemic response in her role as Director of Public Health.
And then of course COVID, there was Ros 24/7, just inspiring, helping all of her colleagues work step by step into the most challenging, unprecedented of times. And Ros's passion and her leadership and her professionalism just seeped through everything that she did in the most difficult of times, be it our local public health team, us as Public Health Wales, her partners with the local authorities, environmental health officers. She was the barometer, she was the compass in Hywel Dda region, just to help people stay together, work together and protect the people in Hywel Dda.
Despite the intense pressure, Ros never lost focus on the human impact of the pandemic. She knew that the greatest asset in Hywel Dda is its people. She protected those who were vulnerable, championed those who went above and beyond, and supported those who she worked with. Ros created a development culture within the Health Board, supporting and encouraging innovative and adaptive ways of working and focusing team efforts through her can-do approach.
Ros's leadership style was just support. She taught her teams and the wider directorate and everyone around her to be big, bold and brave, and to always ask forgiveness, not permission. And she backed that up so people were able to live it, because we knew that we always had Ros's backing in everything.
And to build that into the approaches and to the solutions that we co-produced together. So in that she really kind of lived the principles that she espoused, you know, and actively carried those through into the work that we did.
She brought laughter to the team. She brought an incredible persistence. She never gave up. and I think she lifted the whole team. I remember having one-to-ones with her when we were going through our objectives, and we just spent the whole time excitedly talking about all the opportunities that she could see ahead. She was such a positive person, and she was one of those rare people that genuinely brings joy to work.
In March 2022, ill health led to Ros's retirement. She still showed a huge amount of support for colleagues and especially members of the local public health team during this time.
Her advice to us was it's always the right time to do the right thing. And within the directorate now, you know, we've got a bit of a mantra that is what would Ros do? And we know that if we have got a difficult situation or we've got circumstances where we're not sure which way to go with something, you know, thinking what would Ros do will always have us on the right path.
The legacy of this amazing woman lies in the hearts of all those who she touched with her energy, optimism, determination and humanity. It also reaches far wider, across every community in Hywel Dda, where her vision will lead to real improvements in the health and well-being of the whole population.
Yeah, I think there are many people in West Wales who won't know Ros's name, but actually are going to feel the impact of her being with us for the time that she was through the rest of their lives. We are, as an organisation now, so much more focused on preventing disease, on trying to keep people well, trying to keep communities resilient, and that's Ros's legacy. And I think that will be felt in the way that people lead their lives, actually, in many years to come.
Ros just inherently wanted to work with people, for people, and Ros's legacy will live on in all of us, but also in the work of Hywel Dda.
Ros's passion for health and well-being was clear to see right to the end.
Ros was really passionate about sustainability and about use of green spaces to increase people's well-being and just making sure that those green spaces are still there in the future. And she and her family came up with this idea of Ros's Rainbow Woodland, and with the money raised from the board and subsequent money that that she and her family and her friends and her colleagues have raised since, Ros's Rainbow Woodland is going to become a reality, hopefully later this year. And alongside that, again, Ros has worked with partners that she'd known throughout being a DPH to ensure that that was accompanied by an education programme which is going to help children throughout the region then to understand more about sustainability and the importance of our outdoor green spaces. Just a brilliant legacy.
Over the next couple of months, we'll be working with schools from across Pembrokeshire in order to plant trees. This will hopefully encourage young people from across Pembrokeshire to see the benefits of the outdoors and will benefit from the trees, and I can think of no better tribute to Ros than that.
Following Ros's death, tributes poured in from far and wide. Anyone who had ever been in a room with Ros would have felt her passion and energy and remembered her impact.
And I'd just like to take this opportunity to thank Ros on behalf of the Health Board for the legacy that she's left, the leadership that she showed, and we're in a much stronger position to be able to provide healthcare to the population in West Wales and beyond because of Ros. Thank you to Joe and the team for putting that together. And I think there's one thing that came out of that quote that I think we need to hold on to, especially now. It's always the right time to do the right thing. So thanks so much. We're going to take a break now. Okay, how long for, Joe?
So we have scheduled half an hour in chair, but to give people lunch because it's 2:15.
People want half an hour or 20 minutes, 20 or 15. 15, and then we can get through it. That's how long does it take to eat a sandwich? Yeah, 15 minutes. Yeah, is that grand? Thanks everybody.